And we're live.
Well, good morning, everyone. Welcome to the 8th annual Cost Trends Hearings. As most of you know, this is one of the most important activities of the Health Policy Commission, which is established in law for the Health Policy Commission to put together a meeting which summarizes the major health activities in the Commonwealth of Massachusetts. And of course, this is a year like no other. It's pushed the limits of our system in ways that we only, I wouldn't say dreamed of, more like feared, but we are still strong and resilient. And I want to take this opportunity in particular to thank our Secretary of Health and Human Services, Mary Lou Sudders, who has been at the center of much of the activities in the Commonwealth during the year. I also want to thank David Seltz for all he's done, both for the Commonwealth and in a more parochial way for our little commission, and for leading the staff. The staff, I know I've worked with them to put this together, and I'm really looking forward to this activity. It's significantly shorter in time from what we normally do, but from my assessment, it really sort of focuses very directly on the major activities and major issues confronting the state. So let me not take any more time away from the events and turn the program over to our Executive Director, David Sells. So thank you all for attending. David?
Thank you, Stuart. Good morning and welcome everyone to this year's virtual bubble edition of the Massachusetts Super Bowl of Healthcare, the Health Policy Commission's annual Cost Trends hearings. This morning, we're so pleased to be joined by the full HPC's Board of Commissioners, including the Secretary of Health and Human Services, Mary Lou Sudders. Thank you to all the commissioners. We know how busy your schedules are and how important it was for you to be here today. In addition, I'd like to recognize the many state legislators and legislative staff from both the House and Senate that are viewing this hearing today. Thank you for your continued partnership and support. And finally, to the broader health care community and members of the public from here in Massachusetts and around the world, welcome. Your ongoing engagement and interest in Massachusetts healthcare reform and the innovative work of the HPC is essential to realizing our shared vision of better health, better care at a lower cost for all people. A few brief logistics. The agenda for today's hearing and biographies of all of our panelists and commissioners is in our online program book, which can be found online on our website. A full recording of today's virtual event will be available on our site after the hearing as well. And while we couldn't be in person together this year at our longtime host, Suffolk Law University, we encourage you to engage in the online dialogue while using the hashtag CTH2020. The annual Cost Trends hearing is a uniquely Massachusetts tradition, a yearly public checkup, if you will, on the performance of the state's healthcare system, with a particular focus on healthcare affordability and spending trends relative to the benchmark. The benchmark is foundational. to the state's landmark healthcare cost control law passed 8 years ago, and that is now viewed as a national model for state-based policy innovation to restrain excessive healthcare cost growth to the benefit of families, individuals, and employers who bear the burden of our high-cost healthcare system. The imperative to address healthcare costs and those very real, everyday affordability challenges is as essential as ever and will always be core to the HPC's mission. But as you said, Stuart, this year, as we all know, is very different. The healthcare system, including its leadership and frontline workers here in Massachusetts and across the country, has and continues to experience a once-in-a-generation trauma and disruption in responding to the novel COVID-19 pandemic. At the same time, the pandemic has further exposed systemic racism in our society and the unjust, adverse circumstances facing communities of color as Black, Indigenous, and people of color have contracted the disease and died at higher rates than those of white individuals. Therefore, this hearing this year will focus on exploring and examining these two critically timely and important dynamics of the COVID-19 pandemic, summarized as assessing impact, advancing equity. Today's hearing is an opportunity to not just reflect on the significant challenges of the past 8 months, but to identify those promising innovations and lessons learned that will inform our collective action to rebuild, reform, and reimagine the payment and delivery of healthcare in the future. We're thankful for all of today's speakers, video participants, and expert panelists who have generously agreed to participate in today's conversation on how best Massachusetts can achieve a more transparent, accountable, and equitable healthcare system to the benefit of all. With that goal in mind, I am so pleased to introduce our first speaker, providing remarks via video, the Honorable Governor of the Commonwealth of Massachusetts, Charlie Baker. Massachusetts was hit harder and faster than most other states at the very earliest stages of the virus's spread in the US, when knowledge about the transmission and treatment of COVID was largely unknown. Yet despite this challenge, Massachusetts is now widely considered a model state for its response. This is due in no small part to Governor Baker's data first, science first, public health first, people first response to COVID-19. Governor Baker took decisive action in the earliest days of the pandemic to protect the health and safety of our communities, and has continued to demonstrate thoughtful, transparent, reflective, and honest leadership at a time when so many of us are and continue to be confused and scared. Governor, you've been consistently clear and direct about the dangers of COVID, the obligation that we all have to do our part, and your hope for the future of a stronger Massachusetts, without underplaying the unfortunate need for personal, painful sacrifices. Your story of not being able to visit your 92-year-old father in assisted living for over 100 days due to COVID was and continues to be a deeply resonant experience for so many. On behalf of the HBC's board, thank you for your leadership, and it is my honor to introduce you, Governor, to provide welcoming remarks.
Morning, everyone. This is Massachusetts Governor Charlie Baker, and I want to thank you for this opportunity to address the Health Policy Commission's 2020 Cost Trends hearing. Thanks to David Seltz for that introduction and for the work that you and your team at the Health Policy Commission do every single day, especially the time and resources you've dedicated to the Commonwealth's COVID-19 Response Command Center. Thanks as well to Dr. Stuart Altman and the entire HPC board, including our HHS Secretary Mary Lou Sudders, who, as you know, has tirelessly led our COVID-19 response effort this year. This year's Cost Trends hearing obviously looks a lot different due to the ongoing pandemic. But even though we are gathering virtually this year, we're grateful that the HPC remains committed to its mission of improving healthcare by analyzing data and engaging key players. Your mission is more important than ever in 2020. As we all know, this year, the Commonwealth's healthcare system has been tested like never before. But through it all, the strength, determination, and resilience of our healthcare workers has been on full display. From our hospitals to our community health centers to our long-term care facilities, the healthcare workers across the system have stepped up, adapted, and adjusted and responded to these unprecedented challenges. Our healthcare workers are perhaps the Commonwealth's greatest asset in fighting this virus, and our administration has been proud to support the healthcare community as we continue to confront this challenge together. Over the course of the pandemic, we've invested over $1 billion to stabilize our healthcare and safety net providers. And with our recent filing of a new nursing home support and accountability package, we've committed over $400 million to the Commonwealth nursing homes. We've distributed millions of pieces of PPE to hospitals, first responders, home care workers, and others. And we've launched a testing and tracing infrastructure that leads the nation. We still have a long way to go. Some of the smartest minds in the world are pursuing a vaccine. Many of them happen to be located right here in Massachusetts. But until then, we'll work with the healthcare community to sustain Massachusetts' progress in fighting this virus. As we continue to battle COVID-19, it's important to consider the ways that the pandemic has changed how healthcare is delivered here in the Commonwealth. When I spoke at the Cost Trends hearing last year, which seems like a million years ago at this point, I outlined a comprehensive healthcare reform bill that we had recently filed with the legislature. We remain committed to enacting these reforms because we believe they'll improve outcomes for patients, drive down costs, and prepare our system for the future. And we believe that this proposal is now more important than ever. In some cases, emergency measures that we've implemented to support our response to the pandemic are highlighting the need to enact many of these reforms on a permanent basis. For example, the adoption of telehealth services during this pandemic has significantly increased access to care. During the height of the pandemic, 75% of mental health clinical visits occurred via telehealth. For some behavioral health providers, as many as 90% of all services and treatment were delivered via telehealth during that time. As you all know, the bill we filed seeks to create a framework to permanently integrate telehealth into the healthcare system here in Massachusetts. If the current trend of telehealth utilization continues beyond the pandemic, we can reduce costs for the healthcare system long-term by shifting care out of higher cost settings. And telehealth also reduces the potential for infections to spread. And we've also seen far fewer patients fail to show up for appointments using telehealth. Our legislation also aims to address health disparities beyond this pandemic and create additional access to services. To that end, our bill allows advanced practice registered nurses to practice at the top of their license. We've seen the benefits of that expansion of scope of practice for nurse practitioners due to the emergency measures we've put in place during this pandemic. Permanently expanding the scope of practice will ultimately allow for more critical care to be provided to more people. And finally, we continue to believe in the importance of shifting the focus of our healthcare system from acute care to primary and behavioral health care. This pandemic has highlighted the importance of behavioral health care, and for far too long, these practices have not been at the forefront of our healthcare system. That's why the bill we filed last year included a requirement that providers and insurers, including MassHealth, must increase spending on behavioral health and primary care by 30% over the next 3 years, while remaining within the construct of the state's healthcare cost growth benchmark. We continue to have productive conversations with our colleagues in the legislature on our healthcare proposal. We look forward to working with them to pass these important reforms. One additional note on how this pandemic has changed healthcare delivery. We recognize that healthcare utilization and spending have dropped over the past 6 months. Even though elective procedures are allowed again, utilization in many places remains fairly low. Our administration's partnered with hospitals and community health centers to send a clear message. Residents should not delay accessing care due to the pandemic. Our healthcare facilities are safe and they continue to implement rigorous infection control measures. We'll continue to work with the healthcare community to make sure residents know they can safely access care during this pandemic. Now, before I close, I want to note the theme of this year's hearing is Assessing Impact, Advancing Equity. Later this morning, you'll hear from expert speakers and panelists on the disproportionate impact this pandemic is having on communities of color. These are important conversations to have, and our administration is committed to engaging in this dialogue and responding accordingly. The Department of Public Health recently convened a COVID-19 Health Equity Advisory Group to evaluate the needs of communities and populations disproportionately impacted by the pandemic. Their recommendations continue to guide our response to this pandemic as we seek to support communities that have borne the brunt of the impact. We've improved race and ethnicity data collection for COVID-19 testing so we can understand and address racial disparities. We've launched free testing sites through our Stop the Spread program in communities that have been disproportionately impacted by COVID-19. There are now 18 overall in operation in Massachusetts. And we're continuing to work closely with communities seeing persistently high levels of transmission and responding with multilingual public health awareness efforts. And we're addressing social determinants of health that have been exacerbated by this pandemic, like food insecurity and housing instability. And we're grateful to the HPC for your work to bring these issues to the forefront. On these issues and on so many others, you've been a terrific partner to our administration. And we look forward to continuing to work with you and our other partners across the healthcare system during this public health crisis, and hopefully at some point beyond. Best of luck with your important conversations today, and I want to thank you for the opportunity to address you.
Thank you, Governor Baker, for providing those remarks and opening today's hearings. We are enthusiastic to continue to work with you and partner with you and your administration on our common priorities. I spoke earlier of the governor's decisive actions at the earliest moments of this pandemic, and there is one decision that stands above them all: the appointment of Secretary Mary Lou Sudders as the leader of the state's COVID-19 Response Command Center. By far, the hardest working state official probably in the history of Massachusetts. Madam Secretary, the Commonwealth is forever grateful for your advocacy and accomplishments on so many issues, particularly related to mental health and substance use disorder, access and treatment. And your dedicated leadership of the state's command center fully embodies your career-long values of honesty, determination, and compassion. Specifically with regard to the Massachusetts healthcare system, you cultivated a commitment to partnership and collaboration between healthcare providers, health plans, and the state, grounded in the shared principles of protecting public health and safety for all frontline workers and the public. Following the spring surge and throughout the healthcare system's reopening process in the summer, you have prioritized enhancing access for patient populations such as children and those with behavioral healthcare needs, and communities of color that have been disproportionately impacted. And that commitment continues today as the state plans for a potential winter resurgence. The HPC has been proud to play a small role in supporting you and the state's overall response effort in collaboration and in partnership with so many exemplary public officials and public servants from across state government. Undersecretary Lauren Peters, in particular, is deserving of special recognition for her around-the-clock work on so many issues, including her significant work in improving the public safety and infection control at our senior living facilities. On behalf of the HPC board, thank you for your leadership, and we hope that you might be willing to provide a few additional remarks and reflections at the beginning of today's hearings.
Good morning, David. Good morning to my colleagues on the Health Policy Commission and to everyone who's participating today. I want to thank, first of all, David and the HPC, because when we were standing up the command center in March, literally, I turned to, in many ways, the best and the brightest, and that included David and the team from HPC to support the command center with data analytics, good thinking, because there is no playbook to a pandemic like this. And in many ways, states being left on their own without clear federal guidance on what states should do in response. So for anyone who wants to know what's inside the COVID Command Center, it is extraordinary public servants, both current and past, who a quick text or a phone call from me or the governor, people just, volunteered and continue to volunteer, by the way, David. So thank you for that. As the governor said, and I'll be brief, it has been a year like none other. And I'm sure all of us will look forward to forgetting 2020 if we can. But in fact, I hope that there are things that from this pandemic that we take to heart and learn from going forward, and not see this as a moment in time, because I do think this kind of global pandemic we will experience another, perhaps not as deadly as this one. And so there are learnings for all of this. Three things. This pandemic has laid bare health inequities that have long existed in our country and in communities of color and other individuals and communities that have been marginalized. And it is an inflection point for us to really think differently and respond differently to those communities and individuals. And I think today's conversation in the Health Policy Commission is very important in that regard. It also laid bare parts of our healthcare delivery system that are not strong, and in particular, our long-term care facilities. And this administration has committed more than $400 million since April, funding and accountability to really strengthen infection control, staffing, and other issues that have obviously existed for a long time in long-term care, and ravaged the health and lives of people who live, the 40,000 individuals who live in our long-term care facilities in Massachusetts. It also brought out some of our strengths in Massachusetts. So I have to tell you, the strength of our healthcare system, our healthcare delivery system, has never been stronger than in April and May and June, when the pandemic hit hard. And there were a couple of weekends where the system felt stretched, but never overrun, as has happened in other states. And our hospital and healthcare system was resilient, nimble, because of the healthcare workers. We stood up alternative medical sites in less than 14 days with 1,000 bed capacity, of which we used less than half at any time. We stood up isolation recovery sites, a first in the country, with less than 5 days notice. High quality for individuals who are housing insecure or under 400% of the federal poverty level, in order to have safe isolation and quarantine. So while we were stretched and strained a couple of weekends in particular, that you saw the collaboration of our healthcare community. It acted and performed as a system. The pandemic also demonstrated opportunity. Telehealth, telebehavioral health, hopefully long-standing systemic changes that we can all embrace in Massachusetts. So it opened up opportunities. The strength of our healthcare system are our healthcare workers, and we need to support and value them. As you know, we believe in data, transparency, and we will continue to iterate the data we put out so that all of us can learn from it. Unfortunately, we will be living with COVID for months until we have a safe and effective vaccine that is widely available. So we need to hunker down. We need to remain vigilant. We need to stay together. We need to have honest conversations about the parts of our healthcare system that clearly need strengthening, and we need to come together on about barriers and opportunities. And I look forward to working with all of you on these days and months ahead. So thank you, David. It's an honor to be with all of you today and to be actually in the Commonwealth of Massachusetts. There's no other state I'd rather be in confronting these challenges together. Thanks a lot.
Thank you, Madam Secretary. And I don't think you could have teed up today's conversation any more perfectly. This really is today around identifying those barriers and opportunities for improvement. As you alluded to, among the many fault lines in our society that the COVID-19 pandemic has exposed and highlighted is the very real intersectionality between race, gender, employment, food security, transportation, housing, among many other social factors, and health outcomes and healthcare costs, quality, and access. To showcase these dynamics, this year, the HPC embraced the virtual-only format of this event by preparing a video compilation that highlights the varied perspectives of Commonwealth residents throughout the COVID-19 pandemic. In this video, you will hear directly from people across Massachusetts with a wide range of experiences, including workers at essential businesses, frontline healthcare providers and healthcare leaders, patients, municipal leaders, and community-based organizations about the challenges they and their communities have faced in the last 8 months, the innovative solutions that they have developed to combat the virus and its wide-ranging impacts, and the reasons that they have hope for the future. Please enjoy.
When the pandemic first hit, it was like a major snowstorm. It was something that we had never seen before. The world has never seen before. People were coming in by the droves. We had to have police outside. We had to have limits of customers, how many could come in at one time.
We knew as a family that we had to come in, make it work, stay open, somehow get product to all these people in need.
The illness hit hard and there were a lot of cases. And gowning up myself in a respirator and PPE and going down and trying to help the nurses on the medical floor. It was very, very hard for especially the medical floors, you know, to wear the respirators day in and day out and, you know, watching their faces get sore and listening to them talk about having to code people or treat people who were dying, and it was more than they had ever encountered in their careers. And so it was very overwhelming, very emotional.
I was working in construction pretty much in my life, you know, since 15 years and around the neighborhood. I was cut a tree by the end of the March, and then some big branches fell in my arm and my hand. So I get stitches, and then 3 or 4 days after I went to the hospital, I start feeling weird, you know. But the symptoms from the COVID is nothing I get in my life before. Like the symptom get 2 or 3 days, and then you change it, another symptom, and then another 2 or 3 days, change it, you know, something else. It was very frustrating because it's nothing you can do.
100 residents in my city have lost their lives. We've seen unemployment rates jump from 3% to 25%. And we've seen thousands of residents in need of rental assistance, food assistance, and just help in general. Our city, like a few other cities that have been hard hit as well, share certain characteristics. We are a city of essential workers, many of whom rely on public transportation to continue to report to work. They live in multi-generational, multi-family homes, and we've seen cases of COVID continue to cluster in single addresses. We
are the second or third city in Massachusetts with the highest percentage of people who work in the front line. About 68% of our patients are comfortable in a language other than English. When you have that much diversity in language, it also means that you have a pretty heavy percentage of undocumented immigrants. When they get sick with COVID, they're hesitant to bring it up because they already feel insecure in their immigration status. They don't want to leave their homes, and it's too crowded to do effective quarantining at home.
Early on, we needed help. We needed help in staffing the DCU center. We needed help in terms of developing and building out skilled nursing facility. And we really needed help in terms of PPE. And so this was the first time in the 7 years that I've been CEO that we put out a call for help.
A good deal of the focus and the emphasis was on acute care, hospitals, and facilities. But we had to ask our clinicians to go into these homes of patients who were COVID positive, and we guaranteed them we would never ask them to do that without the proper PPE. So the biggest challenge early on was access to that PPE.
Communication was key to make sure that we could provide seamless care in a pandemic. As a company dealing with COVID, we've had to create an entire new set of protocols in order to really be able to figure out a way to safely provide service in the home. They never had to do this before. We didn't wear protective equipment. We had to teach them how to put on masks. We had to tell families, here's what you have to do to keep our workers safe.
COVID-19 certainly changed the landscape of home care and hospice and private care services. One of the biggest challenges we also encountered was our staff. We had at one point over 120 employees out on a leave of absence. So here we are trying to deliver care to our patients with limited staff because of, underlying medical conditions, child care issues, caring for a family member.
A lot of our patients are experiencing homelessness, lack of transportation, food insecurities, and so a lot of the resources that we normally connect them to were closed, or there were barriers or extra layer of things that they had to do in order to get services. So for example, if someone needed a detox, they had to go to the emergency room or somewhere to get tested for COVID and then provide a letter stating that they were COVID-free before they can even go into a detox.
There's limited resources right now due to the pandemic. Domestic violence has been on the rise, mental health has been on the rise, and they all go hand in hand. We don't have that support. I think based upon it, those who are not getting their social, emotional interaction they used to get with, say, their peers, providers, friends or family, all plays a big impact in it.
I believe, the isolation and the pandemic itself has just caused an increase in symptoms of depression and anxiety for, our younger patients as well as the adult patient population that we serve. School can be a trigger for adolescents, and so we often have an influx of admissions during the school year. And this year, we did not see a dip in our census at all in regards to the adolescent unit.
Most of the treatment modalities that we use to help our patients cope and then recover require human intervention and human contact. And to stay safe during this pandemic, we, the medical professionals, are advising the exact opposite. So social isolation is occurring profoundly with our patients.
I have MS, and so as part of treatment for that, I'm immunosuppressed, and I'm feeling the weight of 200 and some odd days of essentially isolation. I think that sense of loss of connection to my friends and community is probably the biggest challenge. The longer this goes on, the harder it is to see how am I going to repair things when we get to the other side of having to be this isolated.
We've been able to work with PCPs for patients who didn't want to go to physicians' offices, and we have our nurse or our therapist in the home with the patient providing their visit, and then they video in the physician so that there can be sort of this joint care collaboration with the patient. And I think that sort of innovation is really where we need to continue to head.
We had a business outreach team, we had a community outreach team, we had a public safety team, and a public health team. And those teams would meet pretty much every day to discuss the challenges and the blueprint of reopening. We've been able to use federal and state and local money to help small businesses reopen with their reopening plans. We've been able to provide PPE, and that's also that we can continue to have a thriving small business environment.
One of the things I'm most proud of is our ability to become a testing site, a COVID testing site here in Jamaica Plain. It was key for us to ensure that we limit the barriers of patients and members within the community. You don't need to have an appointment. It's a walk-in. You don't have to have a car in order to be able to drive through to get tested. Through that testing site, folks are getting screened for social determinants of health. Folks are able to pick up fresh produce, and I'm proud to say that as of today, we have tested at this Jamaica Plain site over 9,000 patients.
One thing I'm very concerned about is actually the impact of COVID on non-COVID patients. Nationwide, a number of people showing up for presumed heart attacks or strokes or diabetic emergencies or asthma emergencies has just plummeted. And you know those problems aren't going away. They're just worsening people's health conditions. I'm worried about actually a pretty heavy increase in sort of early mortality amongst our patients in their 50s and 60s. So I'm very worried about actually many more orphans, many more people losing their grandparents when they're young children, and that really severely cuts down on the support network that's going to be available for a lot of our patients. Long term, I see poor educational attainment for our kids because they're dealing with family dislocation and family stress.
What is it going to look like during the fall and winter months when a potential second surge is going to come? And the challenges of the inquiries around this COVID vaccine. Is it going to work? Do we trust it? Especially we know the history around racism and research. Are our telephonic visits going to be reimbursed at the same level as a video visit? How do we ensure that our patients continue to not have any associated out-of-pocket costs as it relates to care relating to COVID?
I mean, I am the support of my family. That tree I cut, it was my last thing I did it, you know. It's tough. It's very hard, the situation we live in right now, because not everybody have a regular job. Not everybody work for a company or factory, you know. A lot of people like me work, you know, and self-employed. If you're not going out of your house, you know, bring meals to your house. But it's not just only my case. I can see a lot of people do the same thing what I do, and then it's hard.
The outpouring of support that we received was just remarkable. The sense that you're in this hazardous situation and that maybe nobody outside knows about what you're going through. It was clear that everybody outside understood what our people were going through and we're thankful for them. And I think we emerged from this with a very different relationship with our community.
My inspiration and my motivation comes from the efforts of our staff. We made a decision, I think it was in early April, to jump into surveillance testing. As soon as we rolled out the surveillance testing, we had nobody with any symptoms, 100% asymptomatic. We got so many positive results on that first round of testing, both residents and staff. That was extremely overwhelming. But my staff at another facility, several hours away, many staff members stepped up, stood up and said, we'll go support that facility. We've been through it. We've had COVID. We know what it takes. We know the kind of work that it takes. And they are heroes, and their willingness to put their lives on the line every day is truly inspirational.
Some of our workers who were definitely not thought of as being vital, all of a sudden became vital. Those folks who prepared our food, they had to learn to adapt. Our environmental services, our housekeepers, they'll never get the credit that they deserve for all the wiping and scouring that they did in our hospitals and in our patients' rooms, because nothing bad happened.
I went to a public health department. It's been instrumental. I can call those folks 6 days a week and they're answering phones. The police, the fire for support on different things. They have been there with us every day. So We are very, very fortunate to live in a community that we have so much support.
I think when you go through a crisis and you come together and you work together and you not only survive, but you thrive during that crisis, I think you emerge stronger. I think the hospitals and the medical groups and the medical society and the state government are working better today than ever before. As difficult as it has been to go through this crisis, I think we're all going to emerge as a stronger healthcare ecosystem than what we had before.
Thank you. I'm going to turn it right over to Commissioner David Cutler to introduce our keynote speaker for today's hearing.
David, thank you. And it's an honor for me to introduce our keynote speaker, David Williams. David is my colleague at the Chan School of Public Health at Harvard. Florence Sprague Norman and Laura Smart Norman, Professor of Public Health, also in the Department of African and African American Studies in the Department of Sociology at Harvard. I think when the history of this era is written in terms of its impact on health, to be sure there will be some credit accorded those who developed vaccines and new treatments and so on. There will also be a chapter, if not multiple chapters, on people who have helped to address the social determinants of health. And David is probably the #1 person in the world who has done that. He brought to life and to study our knowledge of racial disparities in health, developed an everyday discrimination scale that people use to measure the impact of regular interactions, regular discriminatory interactions across the spectrum. He's shown the relationship with health. He has also gone through enormous amounts of literature to demonstrate the many different ways that racial issues and other stereotypes affect health in the population. David is the author of 475 papers. He's been on numerous editorial boards. He's a member of the National Academy of Medicine, formerly the Institute of Medicine, the American Academy of Arts and Sciences. And it's just a great pleasure to be able to listen to him. He's one of the most enlightening speakers and writers that I have ever heard. So I'm not going to delay it any farther, and I'm going to turn the virtual microphone over to David. Thank you so much for joining us.
Thank you so much, David, for your very kind words of introduction. It's truly been an honor and privilege to accept this invitation from the HPC. Is someone going to move my slides for me, or do I control them myself? I'm a little unclear.
We'll move them for you. Please just say next slide. Thank you.
Okay. It's much easier if I do it myself, if that's possible, but if it's not, it's okay.
Sorry, if we could do it for you, we'd appreciate it. Thank you.
Yeah, there's a certain rhythm you get in your presentation that goes much smoothly, but it's okay. We will proceed. So what I will do is to try to give you a high-level overview of the challenges we face, but really also give emphasis to the opportunities that we have in terms of dealing with them. The next slide talks about COVID-19 disparities in the United States, and this is the big picture, and you've seen them. You can see the excess risk for African Americans and Latinos, and the next slide shows you the data broken down in a way that you can't possibly miss the point. If all racial ethnic groups had died at the same rate as white Americans, 21,800 Black Americans would still be alive, 11,400 Latino Americans who died would still be alive. alive, and there'd be 750 indigenous Americans still alive. The next slide indicates that the patterns that we see with COVID-19 in the US is a global pattern, and it's a global pattern for a broad range of outcomes. The next slide illustrates that by looking at infant mortality in the United States for 2015, and you can see the excess risk for African Americans and Native Americans. The next slide shows you data for the UK and shows you that in another society where everyone has access to care, you still see striking racial disparities in health with African American, Black from Africa, Blacks from the Caribbean, Pakistanis have elevated rates of death. How do we make sense of this? The next slide talks about how do we make sense of this? Socioeconomic status is income, education, occupational status is a powerful and potent driver of variations in health around the world. And as the next slide indicates, that if we think of socioeconomic inequities in the United States, we see fairly striking patterns. One example, national data for the United States, looking at the panel study of income dynamics, and you can see low-income Americans have an overall death rate 3 times that of Americans with incomes over $115,000. And there's not a threshold effect, but every higher level of income is associated with a lower risk of overall health. Next, we can see that the patterns of racial ethnic inequities in health, the next slide, there are large racial inequities in socioeconomic status in the US. The next slide shows you income data for the US for 2018. And the next slide shows you the same data broken down by a way that you can't possibly miss the point. So in 2018, for every dollar of household income white households receive, Asian households receive $1.23. Asian households are heavily made up of immigrants, and they have more persons contributing to household income than any other group. But let's look at the historically disadvantaged groups. For every dollar of household income white households receive, Latinos receive 73 cents, and Native Americans and African Americans receive 59 cents. What is stunning about that 59 cents figure in 2018 is that is identical, go back, to the black-white gap in income in 1978. You heard me correct, I did not misspeak. In 1978, the peak year of the narrowing of the black-white gap as a result of the anti-poverty policies of the 60s and 70s and the civil rights policies of the 60s and 70s, the gap had been narrowed to 59 cents. And in 2018, the gap is 59 cents. Has it been stable over time? No, it fell throughout the decade of the 80s. It was not until 1994 it got back up to 59 cents, and it's been a penny up and down since then. Importantly, my point is the persistence of the racial inequities in income are much larger than clearly most of my students think. The next slide makes the point that the large racial gaps in income markedly understate the racial gap in economic status. Next slide makes the point that what do I mean by that? You see, income captures the flow of resources into the household, but wealth, assets, gives us a sense of the economic reserves that households have for income. And the next slide shows the latest data from the Federal Reserve Board showing income differences in wealth. Keep the slide moving. For every dollar of wealth that white households have, black households have 10 pennies, and Latino households have 12 pennies. So these are striking persistence of differences in access to economic resources. Next slide. Just to put this into context, I'm showing you data for the UK, where we see a similar pattern of racial differences in wealth. For every pound of wealth that the white British have, you can see Indians have 95 pence, Pakistanis 50 pence, blacks from the Caribbean 20 pence, blacks from Africa and Bangladeshis 10 pence. So we are seeing kind of inequities across racial groups, across two societies that are quite large and striking. Next slide. When my career started, most researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in income and education, occupational status. And if we looked at persons of the same racial ethnic background at different levels of income and education, race wouldn't matter. We now know that life is more complicated, and I'm going to illustrate that with national data for the United States, life expectancy at age 25. And the next slide shows that at age 25, the average white person, one more click, will live 5 years longer than the average African American. One more click. If we go to one more click, it shows that there's a 6.4-year gap between whites with a college degree or more education and whites who have not finished high school. Importantly, the gap within whites by education, it's also true by income, I'll only show you education data in the interest of time, is bigger than the black-white gap. And the next click will show that the gap within African Americans by education is 5.3 years between African Americans with a college degree or more education and an African American who has not finished high school. At the same time, economic status matters profoundly for health, regardless of your race. At the same time, race matters profoundly at every level of economic status. As the next click shows, that if we look at black and whites who have not finished high school, keep going, we can see a 3.1-year gap between white high school dropouts and black high school dropouts. And that gap widens, the next click shows, as education increases. And this is arguably one of the most stunning statistics I'm showing you today, that the best of African Americans, and remember this is national data for the United States, those with a college degree or more education have lower life expectancy, next click, than African Americans, than whites who have a college degree, than whites with some college, than whites who have completed high school. So what do these data tell us? They tell us profoundly there's something about race that matters for your health, regardless about income and education, but there's also something else profound about income and education that matters for your health. I want to bring this home with the next slide, showing you data for the UK with COVID-19. And this slide will unfold. And so just keep clicking when I ask to click once. So here we have, for men in the United Kingdom, COVID-19 deaths. For black men in England and Wales, the overall death rate, age adjusted, is 4.2 times that of whites, although everyone has access to the National Health Service. For Bangladeshi, Pakistani, it's 3.6 times. For Indians, it's 2.4 times. Now, what happens when we statistically adjust, as the next clip would show, for income and education and housing tenure and so on, the gap is reduced, but there's still a 90% excess death rate for blacks in the UK, even after we've taken all of these socioeconomic status factors into account. And if we go, the next click would show the data for women, and you can see, similar to the pattern for men, a very large gaps by race, ethnicity in the United Kingdom. And then even after we've taken income and education and other demographic factors into account, as the next click shows, you still see the persistence of these differences. So across two societies, we are seeing something profound taking place. Even after we've looked at income and education, something else appears to be driving the disparities that we see. And the next slide raises the question that researchers have been asking for the last 25 years. Could racism be a critical missing piece of the puzzle to understand the patterning of racial disparities in health? And the next slide indicates, as we think of racism, what do I mean by racism? When I use the term racism, I'm primarily referring to a social system, one that categorizes and ranks, devalues and disempowers, differentially allocates opportunities and resources to individuals or groups. It's premised on an ideology of inferiority, and yes, it can lead to negative beliefs and attitudes, prejudice and stereotypes. Yes, it can lead to differential treatment by individuals and social institutions, but the heart of racism is in fact this societal system. Next slide. As we think of racism, I want to make the distinction that is very widely made in common speech today of between individual discrimination and institutional, structural, or systemic discrimination. That's discrimination that's really embedded in the normal processes of social institutions. The next slide, I want to give you an example of this racism and how it works. This is national data for the United States. This is the 2012 presidential election. How long did Americans stand in line on average to vote, at a precinct to vote? African Americans on average to 23 minutes, whites to 12 minutes. You can see 19 minutes for Latinos, variation across groups. Importantly, although we see striking differences, none of this reflected individual behavior of local precinct workers. Instead, as the next slide indicates, it was heavily driven by where you voted and what were the budgeted and space constraints, what was the local administrative procedures, what was the level of staffing. So it was all about policies and administrative procedures, but that led nonetheless to dramatic variations in voting. Let me take that to another level by talking about one of the most powerful institutional mechanisms of racism that operates in American society today, and how that shapes access to opportunity and health in many profound ways. The next slide talks about segregation as a fundamental driver or example of institutional racism. And the next slide makes the point that segregation, it's a historic legacy, but its negative effects still persist in American society today. As the next slide indicates, John Sell wrote a book about the history of segregation. He shows that the framers of apartheid in the early 20th century looked across the Atlantic, saw residential segregation, and thought it was brilliant. And so in South Africa, built apartheid on the segregation they had seen developed in the late 19th century in the United States. Importantly, Sell argues that segregation was one of the single most successful domestic policies of the 20th century in the United States. Why would he say that? Well, the next slide gives you my little illustration of how segregation operates. It is like a toxic emission produced by an industrial plant. And once segregation enters a community, valuable resources disappear. They disappear, as the next several clicks will show, valuable resources like quality schools. Let's keep going, as safe playgrounds, as good jobs, as healthy air and water, as safe housing. Let's keep going, as transportation, as access to high quality medical care are examples of resources that disappear as segregation enters a particular context. How powerful is segregation? The next slide illustrates a study conducted by 2 Harvard sociologists back in 1995. They studied 171 largest cities in the United States. And they said there's not even one city, because of segregation, where whites live under equal conditions to those of blacks. And the worst urban context in which whites reside is considerably better than the average context of black communities. Well, that's 1995 study. What do we know today? The next slide introduces us to the Neighborhood Opportunity Index, one developed by Dolores Acevedo Garcia from Brandeis University. It captures across 24 different indicators of opportunity at the neighborhood level for every county in the United States. And what the next slide shows is that when you look at the Neighborhood Opportunity Index in the 100 largest metropolitan area of the US, 2/3 of all black children and 58% of all Latino kids, 53% of all Native American kids are living today in low or very low opportunity neighborhoods. That's compared to 1 in 5 white and Asian kids. At the opposite end, who lives in very high and high opportunity neighborhoods? Almost 2/3 of white and Asian kids. So it's the opportunity at the neighborhood level, striking disparities still persist in the United States today. These disparities, the next slide introduces us to the idea that they have created racial ethnic differences in socioeconomic status. This is something the next slide illustrates that David Cutler documented for us back in 1997, showing that statistically, if you could eliminate residential segregation, you would in fact completely erase black-white differences in income, education, and unemployment, and reduce racial differences in single motherhoods by 2/3. More recently, the next slide illustrates the work of another Harvard economist, Raj Chetty, who has done an intergenerational analysis using all census tracts in the United States between 1989 and 2015. He looks at the outcomes for the next generation of white and black children, comparing those who begin at the same place in life, controlling on parental income. And he finds that black boys in America, in 99% of census tracts, controlling for parental income, do worse than their white counterparts, even when they start out at the same level of income. Why? They live in neighborhoods that differ in access to opportunity. Black boys do well, as white boys do, if they are in neighborhoods with good resources, but essentially there are no such neighborhoods, or very few such neighborhoods in the United States. The next slide. The point that I am making is, this systemic measure of racism, residential segregation, has produced in the United States large racial inequities in multiple domains of life that do not, in fact, reflect a broken system. Instead, it reflects a carefully crafted system functioning as planned, successfully implementing social policies, many of which are rooted in racism. This is not an accident. This is not an act of God. Racism has truly produced a rigged system in the United States. Next slide. What low economic status means when persons lack access to opportunity, live in segregated neighborhoods, lack wealth. It means, as the next clip shows, even though we are in the same pandemic, we're in the same storm, we're in different boats. And some boats are much better able to weather the storm than others. Next slide. What these conditions also mean is, as was so powerfully illustrated in the video we saw of how access to resources varied dramatically by the resources that households and communities have, that in the face of COVID-19, low-income communities, low-income households face unique challenges that mitigates their ability to fight the pandemic. Next slide. There is a large body of evidence that being lower in economic status, being populations of color, living in disadvantaged segregated neighborhoods, leads to higher levels of exposure to economic stressors like difficulty making ends meet at the end of the month, higher levels of unemployment, higher levels of psychosocial stresses, the loss of a loved one, higher levels of racial discrimination, and higher levels of physical chemical stresses. And all of these stresses combine in powerful ways to put these populations at risk. Let me illustrate that, as the next slide shows, with data from some colleagues of mine at the Harvard Chan School of Public Health that showed the relationship between air pollution and COVID-19, and that poor and minority communities are at higher risk of being in neighborhoods with high air pollution. And if you live in those conditions, then you are more likely to get a severe case of COVID-19 and more likely to die of it. Another stress that the next slide introduces is the stress of discrimination that Martin Luther King suggested could have negative consequences for health. The next slide illustrates one measure of discrimination, experiences of discrimination as a type of toxic stress. The next slide illustrates the everyday discrimination scale that, as David Cutler mentioned in the introduction, captures just little indignities. Being treated with less courtesy and less respect, receiving poorer service than others, people acting as if they think you are not smart or they are afraid of you. Little indignities on a day-to-day basis. What the next slide does is illustrates from more than 200 papers published from around the world of the negative effects of everyday discrimination. High levels of everyday discrimination are linked to incident metabolic syndrome and incident cardiovascular disease and incident breast cancer. High levels of everyday discrimination is linked to a number of subclinical indicators of heart disease and to increased rates of blood pressure, poorer sleep duration, higher levels of inflammation and other biomarkers, higher obesity, and higher mental disorders. So a broad range of risk factors and preclinical indicators of disease have been documented globally linked to just the stress of discrimination. Next slide. And what this all means, researchers are using different terms to describe it. But the cumulative negative impact of exposure to psychosocial, economic, physical, chemical, toxic, the stress of discrimination is really leading to wear and tear on the organism. So that for the average person, your age, chronological age, captures how long you have lived. But for persons of color in the United States, your age is not only telling you how long you have lived. Because you are living under worse environmental conditions, your age is also capturing how long you have been exposed to bad environmental conditions and therefore how physiologically compromised you are as a result of such exposures. Weathering is one of the concepts used to describe this phenomenon by Arlene Geronimus, but these are other terms that are being used. And what we see profoundly, and we see it whether you look at measures of telomere length that shows accelerated aging among populations of color. You looked at measures of biomarkers at particular ages, and you see a 7.5 to 10-year difference in biological functioning at the same chronological age. What this all means, as data from the CDC shows in the next slide, is that African Americans and other populations of color at the same age have markedly earlier onset of disease. We see this for high blood pressure. The next slide shows exactly the same thing for diabetes. And certainly, this matters profoundly for making sense of COVID-19. The next slide gives us an example of a study done in New York City. 12 hospitals, almost 6,000 patients. 57% of all those patients hospitalized had hypertension, 42% had obesity, 34% had diabetes, 18% had heart disease. And as the next slide shows, if we look at among those patients, only 6% had no condition, and only 6% had one. So 88% of all the patients hospitalized had two or more. And what I'm showing you is that the living and working conditions of disadvantaged populations are putting them at risk for a broad range of conditions that makes them particularly susceptible to COVID-19. Next slide. What can we do? What are the potential solutions? Next slide. I want to raise the point that there are several things we need to do. And I begin with one that I think on the short term is really critical. It's short-term economic relief. If the feds don't act, the state needs to act. We need to minimize the burden of economic stress on the health of the most vulnerable. The next slide illustrates two publications just from this week that illustrates the depth of the recession and economic collapse for populations of color. One study showed that only 25% of workers laid off or furloughed at the height of the pandemic have so far received unemployment benefits. Many have applied, and they are at different stages, and there are multiple barriers in receiving benefits. And the next study shows that there's dramatic unequal impact of the recession. Whites have recovered more than half of the jobs lost between April and February. In contrast, continue to unfold in that slide, blacks have recovered a third. Hispanics have seen the largest job losses and have the most ground to make up. One important take-home message as well, given the data I showed not just on income, but on wealth, if we are going to be effectively meeting the needs of disadvantaged communities, we need to consider including assets and wealth as part of the assessment of need, else we dramatically understate the difficulties and challenges disadvantaged communities face. What else do we need to do? The next slide. I have argued that simply providing equal access to care will not solve the inequities problem, and I brought that home with data from the UK to illustrate that. At the same time, I think we need to be much more strategic than we are in the innovative use of medical care to address racial ethnic inequities in health. And the next slide is going to give you an illustration of what is possible by looking at an innovative program done by the state of Delaware. It was a statewide program that provided free colorectal cancer screening to everyone in the state, essentially, and then added colorectal cancer treatment to the program, included special outreach efforts, as well to African Americans and other populations. What has been the results of this program? Fairly dramatic success. The next slide illustrates what has happened with colorectal cancer screening. You can see from 2001, when the program was implemented, to 2009, they have eliminated the racial gap in colorectal cancer screening. And the next slide shows that they have also virtually eliminated the racial gap in the incidence of colorectal cancer by markedly reducing the rates for both blacks and whites. And the next slide shows that they have virtually eliminated the racial gap in colorectal cancer mortality. So fairly striking, fairly targeted strategy. This is not going to be true for every medical procedure and every potential medical intervention, but we need to be much more aggressive in identifying those interventions when we can produce results like this. And as the next slide shows, this comprehensive program in the state of Delaware, yes, had a cost of $7 million annually, but had savings of $8.5 million annually because of the reduced incidence of colorectal cancer. So it literally paid for itself. So we just need to be much more creative with solutions like that. The next slide, we want to talk about other solutions. We need renewed investments in eliminating inequities in the receipt of high quality care. Back in 2000 to 2003, I served on an equal treatment report, the next slide, that illustrated this gap that persists in the United States. And there's research suggests it's still a problem, and we need to not lose sight of that fact. Next slide. We also need to build more health into the delivery of medical care by putting greater emphasis on the need to diversify the workforce to meet the needs of all patients. The next slide illustrates a study that was just published by PNAS last month. What it showed, studying 1.8 million hospital births in the state of Florida over multiple years, when cared for by white doctors, black babies are 3 times more likely than white newborns to die in the hospital. That disparity was cut in half when the black babies were cared for by a black doctor. There's a lot we still don't understand. We don't know what conditions this pattern exists for. We don't fully know in detail all the drivers of it, but it illustrates the potential importance of having a diverse workforce, and we are not doing well right now, as the next slide illustrates. This report from the American Association of Medical Colleges that talked about the fact that in 2014, there were fewer African-American males in the first year of medical school than in 1978. Another strategy, I would argue we need to address election-related stressors to minimize pathogenic consequences of sociopolitical stress for our populations, even as we are in this election season. And I'm drawing on here the next slide, a paper published in PNAS last week that I and my colleagues published. We used data from Kaiser Permanente, Southern California, and showed that in the 2 days after the Trump election in 2016, there was an increase in hospitalization for heart attacks and strokes within that system that had more than 4 million lives. Now it had persons who were had insurance, but the study emphasizes that stress linked to political campaigns, rhetoric, election outcomes literally can directly harm health, and both patients need to be aware of this, and healthcare providers also need to be aware of it. Next slide. I think our long-term strategy, given the centrality of segregation, given the centrality of inequality at the neighborhood level, our long-term strategy has to be making the investments to minimize, neutralize, and dismantle the systems of racism that create inequities in health. Next slide. There are a number of those systems mentioned here. We need to ensure access to care. We need to invest in early childhood. We need to reduce childhood poverty, enhancing income and employment opportunities for youth and young adults, improving neighborhood and housing conditions, providing care that addresses the social context, all examples of strategies we need to implement. I want to elaborate on a couple strategies in more detail. The next slide is going to give an example of what can be done in terms of improving neighborhood and housing conditions. Next slide. This is the example of purpose-built communities. The first project was in Eastlake, Atlanta, and it has had dramatic results in terms of what is possible if we put our minds to it. So next slide, I'm going to go through a series of slides that's going to show what Eastlake, Atlanta looked like. Let's keep going. Back in 1995, keep going. The first slide shows the level of safety as a problem, a very high crime rate. The next, keep going, slide shows it was public housing. The next slide shows that only 13% of adults were gainfully employed. And the next slide shows that it was one of the worst performing schools in the state of Georgia. Next slide, it illustrates what the dramatic transformation has been. There's been a 19% reduction, keep going, in violent crime in that public housing project. Half of the units are qualified for public housing. Half are at market rate. All able-bodied persons are employed. And although over 60% of the students qualify for reduced price school lunch, the school is one of the best performing elementary schools in the state of Georgia. Next slide. It illustrates what can be done. And here are some key principles of the purpose-built model of comprehensive, integrated, place-based solutions, providing high-quality resources to address all of the social problems that disadvantaged communities face simultaneously. Shirley Franklin, former mayor of Atlanta, is the chair of the board of the Purpose-Built Communities, and Purpose-Built is promising free technical assistance to any community in the United States who wants to replicate their model. It shows that the public housing department, with a local community group, with investors, can come together and dramatically transform the disadvantage that often exists in many of our challenging communities in the United States. Next slide. So finally, and maybe arguably most difficult, what is the big thing we need to do? My long-term strategy 3 is we need to raise awareness levels of racial inequities and build political will to address them. The next slide illustrates what's holding us back. What are the barriers to address? Next slide. The elephant in the room, next slide, is these 3 challenges. We need to raise awareness levels of the problem of inequities in health. COVID-19 has raised awareness level, but prior to COVID-19, most American adults were unaware that racial ethnic inequities even existed in life expectancy or infant mortality. And second, we need to build the science base that will guide us in developing the political will to address these inequities. And third, we need to build empathy. That is, we need to identify how do we tell the story of the challenge of the disadvantage that we've saw so powerfully on video and I've been talking about in ways that will emotionally connect and resonate with the general public of the United States. And this point, next slide, is something that W.E.B. Du Bois said so eloquently. A great African-American social scientist of the late 19th century published a book in 1899 entitled The Philadelphia Negro. And he has a chapter in that book on Negro health. And he lays out the inequities that existed back in Philadelphia in 1899. And as he comes near to the end of the chapter, Du Bois penned these words: "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race." And he says, "There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." So he saw the fundamental challenge is that we don't really care. He called it the peculiar indifference. Scholars today call it the empathy gap. And the next slide gives us a recent review paper on the empathy gap. It's a global phenomenon. And that is not looking at what people say they feel, but looking at how the brains of adults respond as they view the suffering of persons of someone of their own race compared to someone of another race. There is a racial in-group bias where we have stronger empathic neural responses. We sympathize and empathize and feel the suffering of what happens to someone of our own race compared to someone of a different race. And we need to figure out how we can much more effectively build empathy, because that empathy is necessary to build the political will to get the initiatives that need to be done to address these inequities in health. Next slide. Why should we care? I want to end on the point that there's lots of reasons for us to care, and we should care because of the values we share as a people and the values and principles we live by. But I also want to make the point that there's a mountain scientific evidence that we should also care because allowing these inequities to continue is costly to all of us. Next slide. This is the cost of inactions that these inequities, racial and socioeconomic, costly to our society. Next slide. This is work of Bob Cheney, Will Dow, and other economists showing that if all Americans had a health of the college graduates, the best off in the U.S. in terms of health, the U.S. economy would save $1 trillion annually. That would, if we could eliminate socioeconomic gaps in health. The next slide shows what Tom Levis and Darrell Gaskin documented for racial disparities in health, costing the U.S. economy $309 billion a year. The next slide gives examples of a work done by the Kellogg Foundation and Altarum Institute. And they have calculated what would be the annual additional economic benefits if we eliminated racial inequities by 2050. And the annual additional benefits are $8 trillion to U.S. GDP additional, an additional 3.3 trillion in earnings. The next slide gives more examples. Additional 2.6 trillion in consumer spending annually, additional 1.4 trillion in federal tax revenues. And so you can see an amazing number of benefits. Next slide. Citigroup recently calculated that racism has cost the U.S. economy $16 trillion loss in GDP. So my point is, these inequities, in addition to the moral reasons and the values reasons we have, they are actually a drain on us economically, a drain that we cannot sustain as we look to the future. Next slide. I want to leave you with two quotations, two of my favorite speakers who have inspired my life. Martin Luther King said, "True compassion is more than flinging a coin to a beggar. It understands that an edifice which produces beggars needs restructuring." We have inequities that are not happenstance. They have been produced by edifices, and we need to work together to restructure them. And finally, I leave you with the words of Robert Kennedy. Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. We, each one of us, can be a tiny ripple of hope. And together, we can work together to sweep down the mighty walls of oppression and resistance. Thank you so much for your time and attention today.
David, that was phenomenal. Thank you so much. I know we're short on time, but I do want to see if anyone has anything they wish to ask David. I know we have a million questions and we'll want to keep in contact with him, but let me see if someone wants to jump in here.
Well, first of all, that was a wonderful presentation. I've heard speeches on this subject, but I've never heard such a well thought out, evenly balanced presentation. David, thank you so much.
Thank you.
Thank you. And maybe we can be in touch with you as we move along and the state moves along to get your guidance.
Absolutely. Happy to be helpful if I can. But there are many others in the state as well who would be able to help us, who work in these areas as well.
Thank you. Stuart, shall I?
Yes.
To you?
Well, we're going to move on and we're going to turn to the first panel. And we're going to have Vice Chair Marty Cohn chair that panel. So Marty, why don't you take over?
Can you hear me now?
Yes.
Thanks. Thanks, Stuart. And thanks to Dr. Williams for his remarks. I want to thank our panelists for joining us today. We have a great first set of panelists. I also want to thank each of them and all the practitioners and support staff in their respective health institutions for the work they have done and continue to do during this pandemic to serve the vital health needs of residents of the Commonwealth. I'm going to ask each of the panelists to briefly introduce yourself and in doing so, describe the impact of COVID on your organization, your patients, your staff, and the communities you serve. And then we'll get into some specific questioning. And I'm going to go in the order that you appear in the agenda. So we'll start with Dr. Archer, followed by Dr. James, then Dr. Strongwater, and then Ms. Wilson. Dr. Archer.
Good morning, and thank you for inviting me to speak on such a very important day. I'm in awe of Dr. Williams's presentation. I've seen him before present, but every single time I am moved to sort of lean forward into this work. I am Damian Archer. I'm the Chief Medical Officer at North Shore Community Health, which is a federally qualified health center on the North Shore of Boston. I also sit on the board of directors for Community Care Cooperative C3, which is one of the largest ACOs for mass health patients in the state. Additionally, I'm the assistant dean for multicultural affairs at Tufts Medical School. And so I have definitely seen the intersection of lots of the issues that we've discussed today. In particular, my health center in the North Shore of Boston, which has our largest site in Salem, Massachusetts, and one of the most diverse populations on the North Shore next to Lynn, demonstrates many of the things that were sort of presented by Dr. Williams earlier. When communities have more diversity, unfortunately, there also is an exacerbation of the inequities that occur because of systemic racism and discrimination that are manifested in our infection rates. Salem currently has the second highest infection rate next to Lynn on the North Shore of Boston. And also we've seen where that has manifested itself in the economic disparities as well. That are difficult to look away from. And so, caring for patients that are predominantly representative of the communities of color in the populations we serve as a federally qualified health center, working with underserved patients, the impact of COVID over the last 7 months has shown that even with our greatest efforts of adapting our systems and focusing on the data, following the science, putting people first, there's so many other barriers that get in the way of our ability to meet the greatest needs of our patients because it's beyond the scope of what we can do as a healthcare center specifically. Partnering with the mayors of the cities that we work in and collaborating and I guess looking at the importance of coming together and following the great guidance that we have been given by Secretary Mary Lou Sudders who I think saved our life on March 13th when she said, you know, conserve your resources, provide services to people that allow them to stay safe, and focus on safety first, has really been the thing that has been life-saving for the people that we've served. Thank you.
Thank you. Dr. James?
Good morning. Thank you so much for having me. My name is Thea James, and I'm Vice President of Mission and Associate Chief Medical Officer at Boston Medical Center. And I'm honored to be here today with my esteemed colleagues. I also want to say that great praise for Dr. Williams, because he really, you know, he really represented not only, you know, personal experience, but mainly professional experience as an emergency medicine physician, you know, treating many patients, and the unique insight you have with that role. And we all know this, and I honestly take no pleasure in saying this, but the disproportionate impact of COVID-19 on certain communities was a predictable outcome of this pandemic. And, you know, because of long entrenched racial and social inequities, as discussed by Dr. Williams, that were propagated by decades of discriminatory policy and disinvestment in communities, actually primed communities of color and immigrants and low-income residents, and even people with housing insecurity and addiction. It primed them for a higher risk of exposure, an undue burden of disease, death, and greater economic deprivation as a result of COVID-19. At Boston Medical Center, as you know, the region's largest safety net hospital, early warning signs of the nature and the makeup of the pandemic surge first appeared in our emergency department around early to mid-March. And it showed up as we were beginning to notice that Black and Latinx patients and patients experiencing homelessness were overrepresented in our COVID positive patients. And it bore out in our admissions data as well, all the way through September, because 42% of those patients who were COVID positive identified as Black, compared to 35% for prior year admissions. 34% identified as Latinx, compared to 24% for prior year admissions, and 17% were experiencing homelessness, compared to 9% for previous year admissions. And the surge also hit our hospital, no surprise, before it hit other hospitals due to our population. And at its peak in mid to late April, we had confirmed COVID positive patients took up 72% of our inpatient beds, which is the highest percentage of any hospital in the state. And these factors actually underscore the uneven harm caused by COVID-19. And understanding that Boston's homeless population was particularly vulnerable to contracting, but also spreading COVID-19, the leadership at BMC, alongside community organizations and government partners, actually spearheaded an effort to turn the decommissioned East Newton Pavilion into a COVID-19 recuperation facility. It operated for about 8 weeks during the height of the outbreak, and the facility provided a place to quarantine for more than 250 COVID positive homeless people and individuals who did not actually require a higher level of hospital care. And these efforts were really critical to containing the spread among Boston's homeless community, and it helped to avoid potentially overwhelming the healthcare system. And my colleagues in the BMC Pediatrics Department observed a similar concerning trend among their patients in the early weeks of the pandemic. Mandatory ambulatory clinics were closed, and alongside, because of widespread fears of COVID-19 infection. This contributed, though, to a steep drop-off in children coming in for their regular checkups and immunizations, which had the potential to actually cause outbreaks of preventable diseases like measles. So the pediatrics department partnered with a local ambulance company and launched a mobile vaccination unit to provide immunizations, primary care, and other material needs like food assistance and diapers to patients and their families in the community. I think I'd be remiss if I didn't mention the pivotal role of telehealth in our COVID response, because in our healthcare system, telehealth actually led to a significant improvement in no-show rates. really significant, and it provided greater access to care, especially among behavioral health patients. And in closing, I'll just say that even while we're in the midst of the pandemic, I think, as Dr. Williams was actually alluding to, it is vitally important for us to reflect and to understand actually how we got here. You know, and it requires peeling back the layers of inequity to see all of the intersectionalities and the intersecting reasons why the hurt and the damage done by COVID is not evenly distributed among communities. And only then will we understand the systemic root causes, and only then will it be possible for us to visualize pathways for creating a better, more equitable future. Thank you so much. And I look forward to the discussion.
Dr. James, thank you. Dr. Strongwater.
Yes, good morning, everybody. I'm Steve Strongwater, the president and CEO of Atrius Health, which, as you know, takes care of about 10 to 15% of the population in Eastern Massachusetts, about 745,000 patients. I start out by commending the spectacular presentation by Dr. Williams and the really cutting edge work by Dr. Archer and Dr. James. We are in awe and we try and learn from them every day. Our thoughts and prayers, of course, go out to anybody who's been infected or who has passed away from COVID. We also extend our deep appreciation for the remarkable leadership of Governor Baker, Secretary Sudders, Executive Director Seltz, and many, many other dedicated servants who have helped us all navigate through this pandemic. Some of you may know that as a result of the pandemic, we set up alternatives to hospitalization locations, drive-through testing. We created a virtual call center with approximately 100 staff to answer questions, separate work streams to develop electronic medical records portals, and most importantly, and I think this was mentioned by Dr. James, we deployed overnight and trained hundreds of people to use telehealth, which I believe is going to be an important tool for health equity going forward. We are now 7 months into COVID. We fear that preventive care is being missed because patients are afraid to get in-person care. And I would emphasize what the governor mentioned in his video, that we want to assure everybody that it is safe and appropriate to get your care in ambulatory and hospital facilities. COVID-19 is going to be endemic. It is here to stay. It will be here for quite some time. I would be remiss if I didn't mention that independent practices like Atrius Health are struggling and will continue to struggle because we are under significant financial and operational stress. And without the support of the state and federal government and flexibility from commercial payers, we predict practices will close and or consolidate, leading to potentially higher healthcare costs in the Commonwealth. We have already seen a significant increase in mass health enrollment. We are concerned that high unemployment, Massachusetts has the 7th highest unemployment rate in the country, will lead to increased use of mass health Medicaid, putting pressure on the Commonwealth's funds, finances, and of course, on our practice. We believe that continued telehealth coverage is essential to assure health equity and universal access. We fear that adding co-payment requirements, as some national payers have recently done, will worsen access and magnify health inequities. We think there are many things that can be done virtually. During this COVID crisis, we did health screenings and screenings for social determinants virtually using telehealth as a tool. And of course, we believe that telehealth is an important safety tool as well. Again, I thank you for the opportunity to participate this morning and happy to answer questions when it's appropriate.
Thank you, Steve. Ms. Williams.
Good morning. I'm Deb Wilson. I'm the president and CEO of Lawrence General Hospital, and I am truly honored and appreciate this opportunity to share how Lawrence General dealt with the intense COVID-19 pandemic. And I want to echo what the other panelists have said about Dr. Williams' presentation, because it absolutely resonated with me. As a way of background, I spent the last 9 years at Lawrence General, and before that, 12 years in Brockton. So I've been over 21 years in communities that have been socioeconomically disadvantaged. So thank you for this opportunity. And I also share many of the experiences and thoughts that the other panelists have already commented on. As a way of explaining the magnitude here at Lawrence General, we also at times had more than 70% of our inpatient capacity utilized by very, very sick COVID patients. So it was absolutely intense. And many of those patients had comorbidities and were of color. So this is absolutely, Dr. Williams' presentation resonates with us. And we look forward to driving towards the improvements that Dr. Williams mentions as part of our future. Just in terms of what we did quickly, some of the comments that were already made, but we wanted to be there for our community. We set up a 24/7 hotline. We have an 8-lane testing site, as Secretary Sudders mentioned, with that partnership with the state and the city and with other community partners. We have just launched a mobile unit because we realize that not everyone can get to the testing site. So we've been able to bring it to the neighborhoods and get them tested because they can't socially distance. And we know that that will help. We did everything all other hospitals had to do. We increased our ICU capacity, ventilators, daily fight for PPE. Our staff, fortunately, we only had 134 that were afflicted with COVID, and we're thankful for that. But we were really in a very, very intense situation for this hospital, and I look forward to the panel discussion today.
Thank you, Ms. Wilson. I want to start our round of questioning today, picking up on Dr. Williams' remarks by focusing on the issue of health equity. The core of our collective public health is to create conditions for all people to be as healthy as possible. COVID has put a spotlight on the fact that certain populations, most notably people of color and low-income individuals, have been disproportionately affected by the pandemic in terms of illness, death, loss of income, as Dr. Williams pointed out, and are also at increased risk for food insecurity and housing instability. If you could each tell me what your organization is doing to address these disparities, what are your ripples of hope, to use Dr. Williams' remarks, and what specific policy recommendations might you have for us to consider as we work to address health equity in our state's healthcare delivery system? And we'll go in opposite order. So Ms. Wilson, I'm back to you.
Well, we're fortunate, thank you. We're fortunate that we are in a Medicaid accountable care organization with our federally qualified health center. And so we are blessed to be working with passionate providers that are very focused on the community's needs. Through the Medicaid accountable care organization, we are focused on social needs. We have processes to reach out to those that have housing insecurity. We're also working with the City of Lawrence and the bodegas to make sure that there's storage and food supplies and nutrition issues. But I'd say that most of our work is being done with the health center and through our Medicaid accountable care organization. And we're seeing progress, but it's a daily challenge to reach these patients that are in need of basic supplies and basic needs to improve their health status.
Great, thank you. Dr. Strongwater? You're muted.
I apologize. Thank you for letting me know. I could have gone on for quite some time. We have approximately 36,000 Mass Health members, also in an ACO. We have, throughout the pandemic, tried to provide the same high caliber standard of care for everyone, irrespective of who the insurer is. I'll go back and say that virtual health meaning telehealth, has been extraordinarily important, as I mentioned earlier, in screening for social needs. We reorganized our care and case management program to help our members to address very important issues like preventing eviction, loss of utilities, maintaining employment, and educating patients on specialized programs they may not be aware of. We have work closely with Mass Health for the Flexible Services Program, particularly as it relates to community savings or medically tailored meals for adults with Medicaid, things like diabetes and the like. We have changed the way we measure and monitor our performance internally. We have a series of metrics that we use for feedback to our clinicians. We've incorporated those social determinants into those tools as a measure of quality and safety. And of course, we continue to work in diversifying our workforce to kind of mirror the clients and patients who we serve. And we have made some progress, although I must admit that we have a long way to go. Our role largely is to keep people healthy and to keep them out of EDs. So education and behavioral health services have also been really critically important throughout this period of time.
Thanks. Dr. James?
I think we're starting out by looking at ourselves internally. And I think something that, maybe we're all doing right now, making sure, looking at the very, very basics and foundations, things like looking at who's at the table, who's sitting at the table. Are there diverse perspectives, experiences, and voices at the table? Do the people at the table represent, the proper and the best opportunity for us to achieve equity? And we're also looking to make sure, looking at our clinical operations and looking at data based on equity to see where there may be some inadvertent or some inequitable things that we may not be aware of, or things that can give us some insights into creating a path forward. We're doing the exact same thing for care delivery models to try to, look at, the way forward. And something that's very unique, about us is that we are a safety net hospital. And by definition, we disproportionately treat patients who are, at the federal poverty line and below. And so what we know for a fact is, when we look at the really root causes, and lots of root causes, but one of the fundamental ones, as highlighted by Dr. Williams, is, the difference in economic mobility opportunities that would actually take care of and keep a lot of people safe, in terms of having their own safety net. That said, we're also looking at opportunities, and I'm answering the question you asked about what we might suggest. We're looking at sort of incorporating, as a safety net hospital, most hospitals are filling gaps for people, just keeping them up, but it doesn't exactly define meet the definition of equity, which is people being able to achieve at their highest levels and, without being systemically obstructed in any way. And so when we think about subsidies, things like public housing, and as a perfect example, we're looking for ways, and what we would recommend is opportunities, definitely fill the gaps that we have, but sort of restructuring these things in a way that provides opportunities out of that. I'll use the example of public housing, where some public housing has limited, it puts limitations on how much income you can earn without losing the housing and other subsidies. I know there's federal things involved in this as well, but it creates a bit of a trap, because people in HR tell us people turn down jobs, turn down promotions. So it keeps them generationally stuck in that space. But there are some opportunities we can leverage that exist already, that we could scale and provide opportunities for people to get out of the line of need. And I would sort of recommend that for every policy, every subsidy type of initiative that we have in place. And last, I'll give just another example. We think about when people were receiving the $600 a week for unemployment, but when people got that, their SNAP subsidies were taken back. And it's almost like saying, well, now you have $2,400 a month to live on. You don't need food subsidies, as if any of us live that way and thrive. So, and the only other last thing I'll say is that we're also incorporating patient voices at the center of everything that we are doing, because we don't want to pretend that we know what's best for anyone. I think people can define what matters to them, what they need to thrive, and we're partnering with them to learn from them so that we can achieve what we're trying to achieve, which is equity.
Great, thank you. Excellent points. And finally, Dr. Archer, and then we'll open it up to the rest of my fellow commissioners for questions.
Great, thanks. And, in addition to what others have said, we've definitely done the deep dive and looking at, the ideological sort of differences that we have about the patients we serve. Institutionally, like what does that mean to look at discrimination and racism as one of the things that may be impacting our patients and causing inequities. And these are discussions that we've had on more of an interpersonal level, but looking at it as an institution and saying, we don't discriminate, but where are we being anti-racist? Where are we actively fighting against the systems that cause oppression that we can't look away from because we see the inequity? We see the numbers, we see it again in another, as Dr. James said earlier, we saw this coming. We hoped that it wouldn't happen, but it was a train wreck that impacted more significantly a certain population of patients. So looking at the institution itself, and also the work that needs to be done at an interpersonal level, as well as on an individual level. And at all of these levels, I think the North Shore Community Health, as well as Community Care Cooperative, has been doing the work of having these discussions, not just to talk about it, but to say, how are we going to act? What are the things that we are going to uncouple and change that will reduce the impact of inequities and disparity on the patients that we serve? And that's a lot of work. That's time that's taken away from the operational sort of fixes that we're used to of getting things to work well, but what is it working well for? What is it not addressing when we only look at setting up systems that perpetuate the same thing again and again? And what cost does it have, as Dr. Williams said, by not taking the time to step back and say, what are we not doing that is going to be beneficial to decrease the disparity and equities that our patients suffer from? Specifically, I think something that I would recommend and suggest that we need to look into is the inequity that will exist if telehealth continues by not allowing to pay for telehealth as a service, regardless of how it's delivered. Telephone has been available for 150 years. And in 1 year, we saw the impact of opening up that access to being able to talk with a provider, a nurse practitioner, a PA, or a physician about your medical concerns that wasn't high-level triage, which was really focused on diagnosis and treatment plan in a safe way. And what many of our patients have said, especially those patients that suffer or live with, substance use disorder, mental health conditions, and need psychiatric support, is this is the best care I've ever received because it was full on just for me at this time in a space that I could make as private as possible. So making sure that our systems are able to provide equity in that delivery and that someone's specific type of technology access in their home because they have Wi-Fi or not have Wi-Fi, or phone or not have phone. I think we need to look at the service that is provided, not how it's delivered specifically. Is it helping to decrease a disparity? Is it helping to decrease an inequity? And how does that help all of the patients that we take care of by providing maximum access to the care that patients need?
Wonderful, thank you.
Mr. Cohen.
Open it up to my fellow commissioners. I know Don Berwick, I saw in the chat you had a question. Don?
Thank you, Commissioner Cohen. I wonder what specific social determinants of health have been most difficult for the panelists to meet, and specifically, are there any regulatory barriers that you would like to see relieved?
Maybe I can just comment that I think the biggest single problem is homelessness. which is not something that we're adequately supported to fund. And has to be a partnership at multiple levels to address. People who are homeless just can't take care of themselves pretty much as well as they could. I think the one solution that we are addressing with telehealth is transportation. Of course, the other is access to food, which we're all working on in a variety of ways, but is really hard as well. You heard just taking away SNAP. So it's homelessness first, and then some of the other social determinants to follow.
I would also, add to that to say that, which underscores Dr. Archer, what our Dr. Archer said is being able to maintain support for telehealth, particularly for patients who, there may be, a divide in, people who have internet access and not. The phone has been amazing, and our increase in show rates have mostly been by phone. So, support for that would be really, continuing to be able to do that would be really important and impactful. And I agree also around homelessness. I mean, even through the Accountable Care Organization work that we've done, even in being able to, reduce things like ED visits and admissions, the greatest challenge, the difference in being able to move these things and not homelessness seems to be, one of the major issues, major challenges.
One other thing that I would add is we have one of the busiest emergency centers in the state with 67,000 visits, and that volume is down, and that's probably a good thing for unnecessary non-emergent ED visits, but our behavioral health census has doubled. So I would just encourage the continued focus on how are we going to solve for the serious behavioral health needs and access to those services, because we struggle with that.
Which are continuing to multiply too.
Yeah, the governor's proposal to make an investment in behavioral health and primary care is a structural solution to a number of these problems. I would add that the way primary care is reimbursed should move out of fee-for-service and into some kind of global budget, which would add another structural solution to improving access.
Other commissioners want to chime in?
Yeah, Marty, let me follow up on what Deborah just said, and Dr. Strangewater. There are three pathways to provide more activity within the health system. One, I appreciate what has been said by all the panelists, that you are looking inside yourself, inside your institutions, on things you could do better. And obviously that's the first place you can go. The second, of course, is government. And we've heard and sort of very much appreciate our state activities in this area. And we wish that the federal government was as willing to be expansive. But what about other aspects of the delivery system? Are there in other words, as you take the healthcare system in the lodge, are there activities that is going on that could be redirected, not necessarily by yourselves, but by other components of the delivery system that could help you with your missions? Because not only are you first responders, you are first responders of first responders. You are the groups that are most impacted, with a few others, on what's going on. So as you look at the healthcare delivery system in the Commonwealth, are there other areas that we maybe the Health Policy Commission could help you in sort of redirecting?
Get myself into a little bit of trouble, but I think the work has started insofar as using analytics to do risk adjustments around given populations and to give more appropriate reimbursement.
That's exactly the right answer. It's that kind of, not necessarily that one. Thank you, Steve. Yeah, using risk adjusters to allocate resources, not just patient days.
Yep.
Good. David, put that down, write that down. Other areas, Dr. James, Dr. Archer?
Perhaps a great focus on intentionality around equity. I mean, being very, very intentional about what we are trying to achieve, because, and that, by the way, is the most challenging thing to shift, you know, to shift to that mindset. Because if we don't, and Massachusetts is an amazing state, you know, and, you know, run by an amazing government. And that said, you know, we have these opportunities and resources, you know, and even our, you know, coverage of healthcare and that type of thing. But if we don't have an intentionality about what we're trying to achieve, we could really easily use these great resources we have to recreate different versions or more sophisticated models of what we are presently already doing. And so we have to have an intentionality around that. And it's something that has to be raised constantly until it just becomes a part of our DNA, you know, how we do things.
The only thing I would add is we've absolutely looked inward also, and I'm excited that our Diversity, Equity, and Inclusion Committee is going to a whole new level. We were unfortunately focused on the class standards, and now we're really spending a lot of time, and there's huge energy around this issue. But what would be helpful would be the data, and we want to understand ourselves, but we also want to understand what's going on in the state. So knowing the health status of communities and by disease, by comorbidities, by census tract, it would help focus the attention where it needs to be. And so we really, you know, we're doing our share inwardly, but we also would look to, you know, others to say, this is really what's going on across the state and where resources need to be focused.
I also want to add a couple of points to this. I think one thing that was very stark in terms of as a community health center in the pandemic and the communities we served, we recognized the need for public health to have a blood transfusion. We need to invest, I think, more significantly in a robust opportunity to partner with more public health officials to amplify the preventive care that we provide as the primary care providers in the health center's walls. So, you know, more public health nursing, more opportunities to provide prevention education, which was a significant part of the pandemic that we learned, right? Like what people needed to prevent infection spread was they needed education about how to stay home and how to do social distancing, and they needed food and money, right? Because food and money is what drove a lot of people out of their homes. They had to find means to take care of their loved ones. And so a lot of the social services that you know, we can try in health systems to support and to make referrals to need help as well. They need to be sort of supported to get people connected to the things that matter to them most before they can move up on Maslow's hierarchy, right? We know that bottom of the triangle of food, shelter, and security has to be something that we enable people to receive in order to be able to engage in healthcare at the next level. Something else that I think is extremely important to focus on as a degree of partnership is recognizing that, you know, MIT has done a significant study with hotspotting, right? Where you identify the users of the system that take the most expense, and even with significant efforts to provide them with medical care, if they lose their home, all of that goes away. So I think in order to help with trending of costs to keep it constrained, a greater ability to partner around the impact of what we are doing, what we are actually doing to reduce inequities and disparities is something that we need to use as a metric. So we know that the metric exists of the disparities in maternal health, in hypertension care, in diabetes care. And if we're not seeing an improvement in it, what we're doing is not enough. And what we're doing needs to change. We need to think of other innovative ways to and get people to embrace the basic needs and for them to be able to engage in their health in a way that keeps them healthy and keeps the cost to our healthcare system at the lowest that it can be.
Thank you. Don, I think you had another question.
Yeah, thanks, Marty. Reflecting on Professor Williams' comments, one of the manifestations of structural racism is in our criminal justice systems. The New York Times reported that 40 of the 50 largest outbreaks in the country have occurred in prisons and jails. I'm just wondering, have any of you reached out to or had contact with our incarceration populations to help them with care and with transitions back to the community? The National Academy of Medicine today has a release of a report that I participated in on decarceration to help control outbreaks in prisons. I'd be curious about your interfaces with that sector.
So I'll just say that we have not, but when I was in Connecticut, we provided the healthcare for the correction system for the state through the University of Connecticut. There may be opportunities to collaborate in that manner. It was a true capitated fixed reimbursement preventive health system, which allowed for early on triage. I think it's a complicated population to manage, even under the best of circumstances, just because of, I don't know here in Massachusetts, but there's a lot of large units where multiple people are living at the same time. They don't have individual isolated rooms, so spread is easy from an infectious disease.
Marty, may I?
Mary Lou, sure.
I forgot to raise my hand, sorry. So one of the, so in Massachusetts, because we have a decreasing population in our jails and prisons, we have not had the experience, and I'm happy to make sure the HPCC has the data of other states. So when there has been a breakout, Dr. Berwick, of which there recently was in the Essex County Jail, which I'm sure Deb and Damon folks know, we were able to, so a combination of the behavioral health and medical provider plus supports from us by putting in rapid testing, we were able to really quickly cohort the inmates so that we didn't have, just like we do in other parts of healthcare, so there was sufficient capacity to really create single room. First of all, there's a number of single rooms now because of the depopulation of the incarcerated folks in Massachusetts. So, and we were able to like quickly help to create cohorted spaces for the inmates. So while we had it was pretty significant up in, because it's just recently been in the press, what happened up in the Essex County Jail. We were able to mobilize, so we have in Massachusetts mobile testing capacity where we can, if there's a cluster in formation, literally send from the command center through the Department of Public Health to augment existing testing. So we have not had that same experience as in some other states. Thankfully, one is because of just the census in our prisons and jails. And secondly, so this is like a little teaser for the future. Yes, we are starting to think about our 1115 waiver, our Medicaid waiver, and actually really thinking about strengthening the mass health benefit with individuals who are incarcerated as both just it's the right thing to do. It addresses health equity.
issues, obviously. So would invite folks into that conversation, which we start rolling out in the month of November. But really how to strengthen the connection of healthcare, and I take that in the broad sense, with both our prison and county jail populations as we think about this. So that is a goal of the next waiver. I'm probably saying things now I'm about to read in State House News that we're still talking about internally, but it's fine.
Thank you, Madam Secretary.
Sorry, Deb, didn't mean to interrupt you.
Deborah,
No.
you wanted to go?
No, I think Secretary Sudders covered it well.
Great. If I could just ask one additional question. I Dr. Williams' presentation where he showed the number of Black infants who didn't fare well when treated by white physicians. And it sort of raises the question, what organizations are doing to recruit and retain more people of color in the workforce, particularly in physician and nursing positions. And I wonder if some of you could speak to that.
Well, this is Deb. We absolutely know that that is something that we need to do. We are trying to understand where are we first, and then where do we need to go and set the goals. But we just hired a diversity officer who is Hispanic and has been with us for 20 years, started and worked his way through as a nurse, worked in the military. So we are absolutely trying to be very, very thoughtful about increasing diversity in our workforce, nursing, physician complement, but it's clearly an issue, you know, that we have primarily a female organization and definitely are not represented. So it's a body of work that we need to address.
Thanks.
Like Deborah, we also have been focused on this even, you know, before now and pre-COVID. We understand the importance of the representation and diversity within our organization, certainly being able to match our patient population, because it does, make a difference. And some of the things we've done is, had intentionality around, diversity from top to bottom. We're looking at not only our clinical organizations, our clinical areas in nursing and physicians, but also administratively as well. And our HR department has internal programs that are focused on and built for helping people move up the ladder, professional development types of programs to prepare people for careers within the organization. And that's throughout our entire healthcare system, including our health plan.
I can speak for North Shore Community Health. I think I'm in a unique position because I straddle both a medical school and the health center. So I see the work that's being done within medical schools to recruit and do better pipeline programming to get Black, Indigenous, and people of color into medical school in the first place, because there are not a lot of people out there to hire into positions, even with the best intention. I think what you highlighted and what Professor Williams highlighted earlier, though, is the impact of bias on care. And that is one of the things that we also need to spend significant work on. And it's not to be colorblind, it's to be colorful, right? To learn that you cannot ignore bias. And in fact, people who ignore bias end up doing more bias. And so having all of our clinicians be aware of the bias that they bring, not because they are bad individuals, it's because it's a systemic problem. It's because of the ideology, the institutional issues, and the interpersonal things that we've learned growing up in a society that has made some people unequal because of the color of their skin. And so being able to recognize that bias and what it could do to care, I think, is one of the things that we also need to focus on, in addition to building robust pipeline programs and hiring intentionally to have better decision-making as a diverser group of people in general.
Great, thank you. I know my colleague, Commissioner Foley, has an additional question on workforce. Tim?
Yeah, thank you. And thanks for the great presentations earlier in the panel discussion. Just to follow up on the workforce issues, just kind of wanting to get some overall feedback of kind of how you feel your workforce has been doing during the pandemic. I know clearly there's been a lot of furloughs and layoffs, kind of where is that at with each of your institutions? Are you back to bringing all your furloughed employees back? Are you seeing permanent layoffs? And then how are you preparing the workforce for the potential resurgence? Clearly PPE was a big issue at the beginning. Do you feel prepared? How are you, again, kind of, as we talked about at the beginning, learning the lessons from the earlier stages to apply them to the future? How's the workforce doing, and how are you preparing the workforce for the potential resurgence that we're currently seeing?
So I'm happy to go. If you asked us in June, I would say that everyone was fairly exhausted, and it was, definitely had been a long few months. We feel that people over the summer got to take much needed breaks. We kept our traveling nurses, so that we could allow for that and allow everyone to catch up on a much needed rest. We're in decent shape with PPE, so that all of those issues that we experienced in the intense period, we hope that we've got that under control. We do have EAP programs for our staff. When I rounded, people were definitely traumatized by what they witnessed, with families not being to see their loved ones, if they were dying, and everything was very intense. So we've had Schwartz rounds, but I think nobody wants to see another surge. Nobody wants to think about being in March or April again. But I do think that people are trying to prepare for that possibility, and we're trying to support them through our human resource programs and wellness initiatives.
I would say something. Oh, I'm sorry.
Go ahead.
I interrupt somebody.
Please.
I was just going to say that, we also were prepared throughout the pandemic for the type of provider burnout that was happening with people. We had support for them. We have a person within our HR department who is supporting the staff, the hospital as well. Again, I think we also are in good shape for the PPE. We actually also opened up our hospital prescription food pantry for the staff, during this entire thing, and people absolutely used it. And I was told this week some are still calling about it. And in preparation for going forward, the messaging, the extra levels of messaging that occurred throughout the pandemic are still occurring now, through our CMO and our CEO, and preparing for what's to come. So all the things we had in place then are still there, but the best part is now we have a runway to it, and we're better prepared than before.
If I may, I think there's a brewing problem that we have not fully addressed. We're open in all of our sites, but we're having trouble finding staff. And that has to do with the fact that there are people who are either afraid to come back, who have a chronic illness, and so they won't see patients who potentially have COVID, or who have major childcare concerns. And despite what I think are fairly aggressive efforts on our part, short of setting up our own childcare program, there are people who just have not been able to come back, and at every level, from medical assistants to physicians. And I think that is the problem. And until we can either find a solution in particular to childcare, we're going to continue to struggle. One of the reasons to allow or support continued virtual care is that it is easier, I believe, to get people to work virtually, even if they have childcare issues, than showing up physically in person. But nonetheless, I think that there are shortages of staff right now in our ambulatory practice, largely for those reasons.
Yeah, I echo what Dr. Strongwater has said about the concerns for healthcare workers, especially those who are closer to the front line. Our front desk folk are the folk that are doing most of the care directly with patients that don't have the ability to do telehealth, for example. And they've also been the group that has been most largely impacted by COVID, because they reflect the same inequities that we see in the numbers that we've looked at. And they're crucial and critical to the services we provide. Every single person in our healthcare system is needed in order to deliver a very complex product. So what I would add to this conversation is the the need for us to make sure that we do not further any moral injury to our healthcare workers, of having them feel as if they are obligated to do things that are unsafe. And so I'm happy to hear that many places have PPE to keep our healthcare staff safe. But it also requires a lot of intentional work by the leadership of our organizations and of the state to say that we are concerned for your health as well as the health of the patients that you are going to take care of.
What a wonderful point to end on. So I think we're out of time for this panel. So I want to thank our panelists. You've given us great insights into our healthcare delivery system during a very difficult time. So thank you. And I can now turn it over to Commissioner Blankney, who will moderate our second panel.
Thank you, Commissioner Cohen, and welcome to our second panel. We are going to move quickly through the process because we believe on the commission that we have a great deal to learn from all of you, and we want to make sure that we give ample opportunity for that dialogue and discussion. So I'm going to ask each one of our second panelists to introduce yourselves. And in doing so, I'm going to ask you to describe the impact of COVID on your organization and your patients, the members of your staff, and the communities that you serve, and to ask you to respond to the challenges posed by the pandemic for each one of these groups. And I'm going to ask you to do it in an impossibly short period of time as we go through the introduction. So I'd like to begin by inviting Dr. Alves Hernandez to start us off, please.
Thank you. Good morning, everyone. My name is Madeline Aviles Hernandez, and I am the Vice President of Behavioral Health and Recovery Services for Gandara Center. We have been in existence for 43 years, and our mission has always been to promote the well-being of Hispanics, African Americans, and other cultural diverse populations through innovative care and especially culturally sensitive behavioral health and prevention services. When thinking about, and when I was invited to be part of this panel, I started thinking about what do I know from before and what do I know now as far as what we do and how we do things. And I started thinking about disparities and knowing that this, and when thinking about disparities and thinking about the fact that they occur across many dimensions, social economic status, location, gender, and then adding to that the piece of health inequalities, and thinking about the fact that racial minorities in this country, the health inequalities are very pronounced, very persistent, very pervasive. When I started thinking about COVID and what has COVID done for the last 6 months, it's pretty much taken that and multiply that by 50 or 100. And we've seen that impact not just in the way that we operate, but also in the services that we provide, in the communities that we serve, and especially in our staffing. I will try to be quick and touch on a couple things because COVID has definitely impacted us in many different ways, like most of our colleagues have already mentioned. It certainly has highlighted lack of access at all levels. Something that our communities were already struggling with, but then because of COVID, that was really, really out there. It was a lot more pronounced. It was the challenges were definitely more. Individuals not having access to phones, for example, and not being able to come to us. Our ability to come to them was significantly impacted. To say that we have relied significantly on the use of telephone, it's a complete understatement. Without having the ability to communicate with our communities by phone and the individuals that we serve, we wouldn't have been able to do what we do. Because that's another thing that became very apparent very early on. Our communities have lack of access. They don't have computers necessarily. And when they have computers, they don't have internet. Or when they do have internet, they had difficulties connecting. So our ability to be able to reach them was severely impacted. And then on top of that, our systems, having to enhance our systems and making sure that we had the infrastructure in place to be able to support that was incredible and an incredible challenge to overcome. Just to give you guys some perspective and give you guys an example, our congregate cares settings, we were dealing not just with issues of staffing because our staff were taking care of their own families, but then our settings became, in a matter of from day to night, they became schools. They became the place where they were accessing their primary care doctor, the place where they were connecting with their clinician or their recovery coach. So it was a lot more that we needed to provide, and a lot more demands that were put not only in our internal system, but also the needs were greater. Another thing that I wanted to point out is, yes, we have had many challenges. Yes, our community has struggled, but for us, something that we have seen what has had such a great impact is the level of functionality, emotional and physical stability of our communities and our individuals have been severely impacted. And I am not just talking about the communities that we serve and those individuals to whom we provide services, but also our staff, the people that we work with every day. Seeing how they struggle emotionally, seeing how they struggle having to cope with the pandemic, the demands, the internal and external demands, family, friends, environment. So there is absolutely no way that we could, that I could successfully put into words how overwhelming that is. So, and some of the things that we definitely put in place, like most of you have said, is we moved all of our services virtually. So that was something that we were grateful to have the infrastructure. We were proud that we were moving already towards that goal, because that has allowed us to really open our doors and expand our reach to our communities and our individuals.
Thank you so much for your comments. It's a rich field, and I've asked you to do an impossible job of giving us an oversight. So thank you very much, Doctor.
Thank you.
Mr. Dreyfus.
Yes. Thank you. Good morning, Chairman Altman, commissioners, and fellow panelists. My name is Andrew Dreyfus, and I'm the CEO of Blue Cross Blue Shield of Massachusetts, and thank you for inviting me to testify. I also want to thank and commend Governor Baker and Secretary Sudders for the extraordinary leadership they've shown during this COVID epidemic. And I also want to thank the Health Policy Commission, especially its esteemed leader, Stuart Altman, who brings great credibility and integrity to this body. I'm going to briefly cover 3 topics: our response to COVID-19, diversity, inclusion, and health inequity, and healthcare affordability. When the pandemic hit our state, Blue Cross acted immediately to balance the urgent need of our nearly 3 million members, our employer customers, our clinical partners, and the broader community. We waived cost shares for medically necessary COVID-19 testing and treatment and covered all in-network medical and mental health visits via telehealth at no cost to our members. We broadened access to mental health services, including permanently paying for behavioral health telehealth visits at in-person rates and increasing reimbursement for child psychiatry. We acted swiftly to help our most vulnerable members. We created a COVID risk index to identify members at highest risk for contracting the virus and experiencing severe symptoms. We use zip codes and socioeconomic status to prioritize outreach in COVID hotspots. To date, our nurse case managers have reached out to 37,000 at-risk members. To support employers, we provided $100 million in premium relief, extended grace periods, helped provide coverage to furloughed workers, and have held webinars for 10,000 participants on issues ranging from mental health to health disparities. We supported our members by we supported our clinical partners by suspending administrative requirements, advancing payments, creating a new value-based payment program for independent primary care practices to improve quality, lower costs, and provide financial support during the pandemic. Finally, we responded to the needs of our neighbors. Our employees worked at the Boston Hope Field Hospital and with the Department of Public Health as contact tracers, and we have devoted tens of thousands of meals from our company kitchens. Through our foundation and our company, we have made more than $10 million in direct contributions to the community in the fight against COVID. Let me move on to the issue of health equity. Blue Cross and Blue Shield of Massachusetts has long been a leader in diversity and inclusion. More than half of our board and senior leadership are women and people of color. We work hard to ensure that our entire workforce feels respected, included, and empowered, and the passion of our diverse employees drive our commitment to racial equity. Our supplier diversity program, which doesn't get enough attention broadly in this discussion, procures products and services for minority, women, veteran, LGBT, and disability-owned businesses. Our company also made a $1 million grant to the New Commonwealth Racial Equity and Social Justice Fund. But we must do more, and David Williams's presentation made that clear, which I think, by the way, should be required viewing for everyone in the healthcare system. And I'm going to make it available to all Blue Cross employees. COVID has reinforced the racism that pervades our healthcare system and has taken a disproportionate toll on Black, Latinx, and Indigenous communities. The causes of health disparities or inequity are deep, as Professor Williams made clear, and include such social determinants of health as poverty, housing, children, nutrition, and racial bias itself. Our company and foundation have been working on these issues for 2 decades, but we have renewed our commitment this year, pledging to join others to fight racial inequities in healthcare. We plan to gather new data from our members, work with healthcare providers to understand patterns of inequities, and introduce targeted incentives and enhanced support to reduce disparities. We also recognize that addressing health inequities will require gaining the trust of our members and accounts, and we look forward to working with the HPC and SHIA in close collaboration with other payers, providers, the community, and government. A final note on healthcare affordability. While the Commonwealth appropriately focuses on COVID and racial inequity in this hearing and more broadly, we cannot lose sight of the urgent need for affordable healthcare. At Blue Cross, we are seeing a worrying rise in the underlying costs of healthcare, driven in part by increases in prices sought by hospitals, physicians, and pharmaceutical companies. If we are to effectively fight the pandemic and racial injustice, we must work to make healthcare more affordable for the public programs and private employers and individuals who pay for care. Thank you.
Thank you, Mr. Dreyfus. Appreciate your comments. Let's move on now to Dr. Nethersole.
Great. Good morning, everyone.
Good morning.
And thank you very much for inviting me to join you today. I will tell you a little bit about my background for those who don't know me. I've been a primary care pediatrician at Boston Children's for about 30 years. And we have a large primary care practice, about 65% of which is Medicaid. And so really very much focused on the ground, on the day-to-day issues of families and children that have significant needs. My other hat is that I'm the executive director for community health for the hospital. So that means I oversee and help to drive our community health mission, which is really focused on children and families in our local community. So it's around programs and services that we provide. It's about partnerships that we have with schools, community health centers, community-based organizations, and public health organizations, as well as working closely with our government relations team on advocacy on child health issues. And so social determinants of health are really very prominent and important part of the work that we do, including our our $53 million 10-year Collaboration for Community Health initiative, which is very much focused on social determinants of health. I'm also actually on the board of our ACO, so I'm bringing a number of different perspectives into this conversation. I want to just talk a little bit about the sort of what's happening or what has happened internally in terms of response to COVID-19, and then talk about some of the external piece. So internally, fortunately, children were not as directly impacted by COVID-19 in the way that adults were in the spring in terms of illness, hospitalization, and deaths. Our response at the hospital has been really more to support pediatric care that was delivered or diverted from other hospitals. So back in the spring, as the other adult hospitals really had to, use their pediatric wards for adult care and their pediatric ICUs for adult care, we took those pediatric patients on, and that was actually a regional effort, not just locally in the city of Boston, but a number of hospitals around the region redirected their pediatric care to us. On the outpatient side, we obviously had a shift in terms of a big shift to telehealth and a limitation of in the primary care space of some of our visits. That big shift to telehealth really skyrocketed in behavioral health, but also in primary care. We did see a drop in terms of kids coming in for immunizations, that actually has rebounded over the summer, and I think we're actually in a pretty good place. But there were a lot of concerns and fears in the community about people actually coming into the hospital setting. As I mentioned, we've over the course of the summer have really ramped up, have prioritized our young kids. So I think we are actually in a good place now in terms of immunizations. But I still think on the behavioral health side, that's a challenge that will only get worse as we get into the fall and winter. We already are seeing sort of a little mini crisis in terms of boarding. There aren't enough behavioral health beds, and we're starting to see that concern. Because as I mentioned, there hasn't been that much of a direct clinical effect on kids in terms, except for the multi-system inflammatory syndrome in children. We definitely have seen that, which by the way, also does have a disparate effect on children of color, similar to COVID-19. I think that as we think about those indirect effects, which are around stress, around watching family members get sick and die, which is around seeing family members be either upset, unemployed, and the issues of poverty, those do have an impact on children. On the externally focused side, we've really been focused on supporting our partners around food insecurity and housing, so directing additional financial resources to our partners to address those issues for families. And as well, thinking about some of the structures that are important in communities. We, over the summer, launched our Child Care Support Initiative, where we are actually giving small grants, $5,000 to $10,000 grants to child care agencies, child care programs, family child cares, as well as centers in the communities that were most heavily affected by COVID-19 in the city of Boston. And so that first round of $250,000 went out in August, and we're doing a similar grant coming up soon. We're also focused on supporting school reopening as well as childcare reopening, and so have been working with Boston Public Schools and with the school nurses to really help ramp up training for that. So we did a four session series for school nurses in Massachusetts. There are about 1,200 school nurses who attended each of those sessions at the end of August. And then currently we are working with Boston Public Schools and specifically with the school nurses to do additional training. So that's sort of a nutshell, some of the things that we've been working on that I think have been trying to address the needs.
Wonderful, Dr. Nethersall. Thank you. It's difficult to get everything in the short period of time we're asking you to do, especially around pediatrics. So thank you. Our final panelist is Dr. Sequest.
Good morning. Thanks for the invitation to speak today. It's a great honor to be a part of this panel. So my name is Tom Sequest. I'm a primary care physician at the Brigham, and I'm the Chief Patient Experience and Equity Officer for Mass General Brigham. As part of this role, I have led our clinical operations response to the COVID pandemic. I want to thank the Governor and Secretary Sudders for their consistent support and leadership during the pandemic, and really thank you for the opportunity to share the Mass General Brigham experience with you today. The COVID pandemic has been, as we all know, among the greatest challenges we've ever faced. And, beginning in March, we all were faced with uncertainty and really a lot of fear. The pandemic dramatically changed and affected all of our communities, our patients, and our workforce in more ways that I could really do justice to today. During the course of the pandemic, our system cared for nearly 5,000 inpatients with COVID, up to a third of them in critical care units. This really required us to redeploy staff to sometimes unfamiliar roles and environments to expand our critical care capacity way beyond our routine limits, and to really adopt an entirely new care model. Maybe the biggest change that many have referred to today is our shift to digital health, which at its peak in the spring reached over 12,000 virtual visits a day, which is more than 60% of our total care volume at the time. Importantly, these programs were really enabled by big policy changes at the state and federal level, such as endorsing new payment models and waiving the originating site requirement that allowed our patients to receive care from their home. Early on, we did establish a community health equity work stream as a formal part of our incident command infrastructure. And we partnered with many of the communities that have been talked about today, Chelsea, Lynn, Mattapan, and others. And before I sort of dive into that, I just wanted to share my thoughts on the public discourse on COVID. I think we have all been saddened and we've really been horrified many times by the effects of COVID on our communities. But I would encourage us all to not be surprised. Longstanding racism, not race, is the risk factor for these poor health outcomes that we've been seeing during COVID. These factors, as Dr. Williams highlighted earlier this morning, have long been with us, and it is our duty and our responsibility to address them moving forward. Our community health equity strategy was really fourfold, starting with expanded testing in hotspots, so-called hotspot communities. We tried our best to help mitigate the impact of COVID through distributing care kits. These care kits would contain things like masks, hand sanitizers, instructions, and multilingual instructions on dealing with the COVID pandemic. We gave out over 250,000 of these kits and nearly 2 million masks during the pandemic. We tried to assist community members with social distancing whenever we could, whether that was through arranging different housing suitability or other programs. And we did a lot of direct outreach via our nurse care managers for our highest risk patients, the patients we thought would experience the poorest health outcomes from COVID if they were infected. We had a lot of approaches to accomplish these goals. We leveraged our existing health centers like in Chelsea and Jamaica Plain. We partnered with other health centers like the Lynn Community Health Centers. And in some cases, we rented RVs so that we could reach out to additional Boston communities. As you know, during our COVID equity response, we confirmed what we long knew to be existing challenges in equity. There were digital health inequities, really massive digital health inequities that only got bigger as we expanded our digital health programs. As has been talked about all morning, housing and food insecurity as the main social determinant of health challenges facing our communities really came to the forefront. Language barriers were an enormous issue and challenge in our hospital. As many of us know, patients who don't speak English as a primary language were predominantly affected by this outbreak, and our ability to deal with that large of a patient population in our healthcare system was a challenge. And mental health and behavioral health and substance use disorders all came to the forefront as well. We are committed at Mass General Brigham to continuing to fight for equity and to fighting against racism. We are launching a new United Against Racism campaign that will help us deal on the fronts of workforce, our patients, and our community. We are committed to establishing diversity targets and accountability for our board and senior management leaders to enable racism reporting and anti-racism training throughout our organization. On the patient care side, we will work to expand access to our care offerings. We will focus on our digital health programs and trying to address some of the barriers that we have seen and observed over the past 6 months. We are working to eliminate racialized medicine and our clinical algorithms and our clinical policies. We are working to establish an equity culture across all of our clinical departments. Many of us have been promoting throughout our organization is to treat equity like safety. It is an urgent crisis, and we can't afford to delay action any further. And we're going to be working in a much more targeted, precision way with our community partners to target health outcomes, whether they be behavioral health, substance use disorder, chronic conditions like diabetes care. We have seen a dramatic, in addition to the impact of COVID on our communities, we've seen a dramatic worsening of chronic disease outcomes, diabetes care, and other care outcomes over time.
Dr. Sequest, I know you have a rich list of things to share with us. I wish we had time to hear the entirety of it. Thank you so much.
Yep.
What will happen next is I get to ask the first question. We'll go in reverse order. So Dr. Sequest, you'll be up first. Following your answers to my questions, we'll open it up to the rest of the commissioners. So I think it's fair to say that we're in a very different place today than we were last winter. We know more. We understand a bit more. Knowing that, how should we be rethinking our healthcare resources and our capacity in the Commonwealth? And that includes everything. It includes hospital care, long-term care, primary care, behavioral care. How do we rethink those to ensure that there's equitable access to care across this continuum? And we'll start with Dr. Sequest.
And actually, Dr. James had highlighted this in the last panel. I think one of the most important things that we can do is be absolutely intentional about what our goal is in the space of equity. And that means that every decision that we make, we think about the space of equity and what its impact on equity would be. Again, like I draw sort of on my background now around safety. Everything we do in our health system, we think about safety first. I really think that we have to do that around equity. That is the way that we're going to really start to understand, are we making the best use of our resources? And are we making decisions every day that are intentional about reducing equity?
Thank you, Dr. Sequest. Dr. Nethersall.
So this is going to come as no surprise from the pediatrician in the audience, but I think that, I think one of the ways that we do this is actually focusing on equity at the very youngest ages. So I think what happens is you start out with disparities in that, in maternal infant mortality, and then that continues to expand over the life course so that by the time kids are in school, that there's an achievement gap when they're coming into kindergarten. And then that continues as they go to be adults. And so one of the things I think that's really critical is that as we think about the resources that we have, how are we utilizing those to provide the best possible start and the best possible sort of health outcome from early on in life, so that we're not constantly playing this game of catch up as we go forward in life for large populations of patients.
Thank you, Dr. Nethersall. Mr. Dreyfus.
Yeah, I guess a couple of points. One, building on what Dr. Nethersall said, I think we have to shift resources in 3 or 4 ways. One, we have to shift resources away from acute care and more towards preventive care. And the best way to do that is to pay differently for care, which this commission has supported, but which our state still needs to make progress on. Secondly, I think we have to look at the distribution of health resources within our Commonwealth and where are the health resources going relative to where the need is. And then finally, I think we have to invest in public health. And this administration has, for example, made some really serious efforts, for example, to reinvest in child protective services or services for people who have developmental disabilities. Our public health infrastructure has been eroded over the last 20 years and needs to be rebuilt. And I think the pandemic gave us a stark example of why that's so important.
Thank you, Mr. Dreyfus. And finally, Dr. Alvarez Hernandez.
I have to agree with Dr. Dreyfus. I think that we need to look at how we allocate health resources, and especially the long ignored, or maybe that's the wrong word to use. We certainly need a lot more resources on the areas of behavioral health. I keep going back to, when I think about these issues, I always think back to the Maslow hierarchy of needs. We need to pay close attention to those things at the very basic and make sure that those things are covered and well supported if we want our individuals to successfully address and reach, healthier, more functional beings emotionally, physically. So just looking at where resources are at and how we can better allocate those resources, I think it's a huge need, especially around areas of prevention, like one of my colleagues just said, areas of behavioral health, and specifically areas of recovery and recovery services.
Thank you, Dr. Elvis Hernandez. I believe the floor is open for questions from the rest of the commission.
I'll ask the first question.
Please, David.
Just about every panelist has mentioned the importance of telehealth as a tool to be able to continue to connect with people and patients throughout this pandemic. And that it's really been a sea change in the way that care is being delivered and connected to people. Dr. Sequist, you mentioned, though, that you had identified some digital health inequities. And I was hoping you could speak a little bit more about that, and perhaps the other panelists have some reflections on that concept as well. And then finally, I guess I would say, after perhaps the other panelists go, Andrew, interested if you think that there is a role for health plans to help address some of these digital health inequities. But Dr. Sequist, perhaps you could start with you.
Sure. So I think that the inequities that we're observing have their roots in sort of a few areas. So one is lack of consistent broadband internet access across all communities. I think the second is the lack of access to the hardware needed for this, whether they be tablets or smartphones that can enable such access. The third is the usability of the tools themselves, whether they be on the EHR vendor side or the app side. None of them are typically multilingual or developed in a way that would enable low digital literacy users to actually use. And then the fourth, I would say, is on the healthcare system side and making sure that we are equitably offering access to all of these virtual health findings. We tend to have our own biases about who may or may not want to use such services and then not offer them. Just for numbers, we see in our patient portal that in a community like Chelsea, we may have about 30% enrollment, and in a community like Newton or Wellesley, we may have 80% enrollment. So just very, very large differences. And patient portals are reflective of our access to all kinds of other digital offerings.
And I can just add into that. We actually looked at the patients that were using our telehealth services, and both looking at who was accessing it, variations by zip code, but also variations by type of device, and very much found a skew towards lower income populations, minority populations, more likely to use cell phones, which provide a little bit more difficulty than with some of the telehealth services. So I think that there's definitely clear opportunities for both device, internet and broadband access, and then actual utilization that's important.
David, one of the decisions we made when we permanently extended in-service payment for mental health visits to telehealth, we did not restrict it to video visits. We included telephone visits. We thought that was very, very important, in part because some people, as we've just said, there is this digital divide that we need to narrow, if not eliminate. And also that we realize that some people just might not have the privacy necessary in their homes to do a mental health visit. And so we really wanted to offer the greatest flexibility at all. And we've, as I mentioned, we've established a new group at our company to look at these issues, and the digital divide is one of the issues we're going to try to address as part of that. So there is a role for plans.
Thank you. I believe Commissioner Cutler has a question, and he's on mute.
Thank you. Actually, my question is slightly tangential, so I'm going to put it aside, Commissioner Blakeney, if you want. But I'll just ask it and then you can decide. I'm sort of wondering about the finances of everything. And I know you work at very diverse organizations, and that some of you, particularly Andrew, have insight into a lot of organizations. Do you have the sense, given what's happened in Massachusetts, that there are organizations that are really very tight financially, where the Commonwealth is going to have to, where something bad may happen and the Commonwealth might have to do something? Or are we have we made it through the worst and things look okay?
I can offer one perspective on it. First of all, just David, in terms of utilization of health services, we obviously had an extreme drop for about 12 weeks in the spring during the height of the pandemic, and that caused a severe kind of revenue loss for a number of institutions, and those, including some community health centers and some safety net hospitals, very difficult. The good news so far, one, there was federal money that came in, and that didn't make up all that lost revenue, but it was a help. The state took some actions through the Mass Health Program. We advanced money in some cases, as did other health plans. Utilization is now back at pre-COVID levels, and in some cases above pre-COVID levels. So we're trying to look at this kind of epidemic and the financial impact over a 2-year period. We actually think there may be part in 2021 as hospitals and other clinics are able to care for both COVID and non-COVID patients at the same time, which they were unable to do in the spring, both because it was new and lack of PPE, that we may see overall utilization, therefore costs above pre-COVID levels for an extended period of time as all the deferred care comes back. However, to be more specific, I think if there are a handful of institutions in the state that are needed for community health and are in trouble financially, the state has a responsibility, and private payers have to play a role in that to help rescue them.
Thank you. I have questions by both Commissioner Berwick, Commissioner Altman, and Commissioner Kreider. So let's start with Commissioner Berwick, please.
Thanks a lot, Barbara. And Andrew, thank you so much for your comments and the whole panel. Andrew, I have a question for you, and maybe other panelists want to comment. 2 questions really about telehealth. One is, you said that you have so far, and I think you said you intend in the future to compensate for telehealth visits at the same level as face-to-face encounters. First question is, do you think that we need to do work to establish a kind of more empirical cost basis for telehealth visits and reconsider how we pay for them?
Yeah, so let me, go ahead.
The second question is, are you anticipating that in the hopefully post-COVID era that telehealth will be layered, telehealth visits will be layered on top of the former volume of visits, so we actually will experience a new stratum of payment that will raise total costs?
Yeah, so that is a risk, Don. So let me go back to your first question and clarify that we are paying during the public health emergency for telehealth visits at the rate of in-person visits for medical visits. We've said we're permanently going to do that for mental health and substance use disorder visits because we've seen how successfully that worked. We have not committed to paying. We're working in the legislature and the administration on this permanently for precisely the reason you said, is that it could introduce just another level of visits and increase utilization. And certainly, for example, I've been emailing with my physician or physicians for years, and I wouldn't think that every email should necessitate an office visit style payment. I think the solution, however, is in something you're familiar with, which we'd like to be on a value-based payment arrangement with all clinicians. And so whether it's an in-person visit or a telehealth visit, the physician is agnostic to it. They would pick the visit that is most effective for the care of the patient and most responds to the patient's needs. I think that's the long-term solution, is more and bigger and deeper payment reform.
Thank you. Are any of the other panelists interested in joining in this discussion? Hearing none, then I think Chairman Altman and then Commissioner Kreider.
Well, all right, let me focus on this issue of affordability that you mentioned, Andrew. A couple of weeks ago, we heard a presentation by the insurance commissioner staff, and he indicated a very substantial increase in payments approved for health plans. You indicated that you are seeing very substantial increases in prices being charged. Can you give us some sense of what's going on?
Yeah, I think there's a couple of things going on. So we have seen underlying medical trends increase, which is driving what I imagine the insurance commissioner talked about, increased premiums. Half of all medical costs in Massachusetts are a result of prices charged by physicians, hospitals, pharmaceutical companies, and other providers. And what we have been over the last 5 to 8 years been able to keep those prices quite low in the 1 to 2% range, the increase in prices, sometimes up to 3%, which has allowed us to stay within the Health Policy Commission's established benchmark. We're starting to see that in part in response to the losses of COVID, in response to, I think, other economic challenges that they face, that hospitals and physicians are starting to ask for much more substantial unit cost or price increases, which is simply going to drive up the underlying cost of care, which in turn drives premium. And I think this is an area that this commission ought to pay more attention to in the coming months and years.
Let me follow up and throw it out to our other panelists as well. Here's my concern, and that is that if we continue with the rest of the healthcare system doing business as usual and cost structure as usual, and then try to add on to that the extra expenses of COVID and related services like telehealth, what we're doing is, as you pointed out, jacking up the prices or costs of the system in a way that you begin to question whether we have the capacity to pay them. And then who's going to lose, whether it will be many of the services that you as panelists who are trying to provide to this new needs, whether you will wind up in the future at the negative end of that. So this affordability issue is not only a large question, but it also brings into focus whether we can go forward and do the right things in the new areas as opposed to what we were doing in the past. So I don't know if any of the other panelists want to jump in.
I mean, I can just say a couple of things, not having as much expertise in this area, but I mean, I think there's a difference between the short term and the long term. Sort of in the short term, we have to acknowledge that we're going to be paying more. We've had an emergency, it's a tornado that's come in, it wreaked havoc. We have to address the issue, address the needs, and it's going to cost more in the short run. I think we're learning some new procedures and structures and approaches that we can put into place for the long term that may allow for the care that we were providing before to be provided in a more streamlined way. And I also think hopefully with, particularly on the ACO side of this, that as we think about some of the approaches that we're using to address some of those sort of social determinants of health or health-related social needs, that will, and as we get more flexibility with how we do that, that might allow for some restructuring of those resources as well.
That's an excellent answer, but the concern we might have is to what extent we don't change in the long run. All we do is add on. So I couldn't buy, I totally agree about the short term and the need to recognize higher spending this year and next year and stuff.
You know, Stuart, if I may, you know, it's been interesting to watch because physician practices that were principally paid on a fixed monthly rate could manage and survive the best through a COVID era where their visits and their revenue dropped precipitously. And so we are hoping that that lesson may encourage more practices to consider that mode of payment. There's also, I noticed there was just an article published which looked at in the Maryland system, which you know so well, having chaired a group there for years, where the hospitals are played on a global basis also didn't experience the same drop in revenue. So this is potentially powerful evidence for us to consider in moving to a more predictable, reliable source of funding that's less based on a fee-for-service model, while still recognizing the extraordinary burdens that hospitals like Dr. Sequist and Dr. Nethersole represent, and they experience in a, hopefully once in a century pandemic that we have.
We've also, I would just add in just to say, in terms of the add-on, our observation over the past 6 months has been that as in-person, so we ramped way up on telehealth. As in-person care returned, telehealth actually has come down precipitously. So we haven't actually seen it as an add-on in volume, but more sort of a displacement between in-person care and telehealth care.
Okay, thank you. I'd like to turn to Commissioner Kreider. You're still on mute, Chris.
Got it.
Okay.
Thank you. Thank you. A couple questions for Andrew. Beyond telemedicine and the lower overhead associated with telemedicine, which would fall into the category of paying less as long as utilization overall did not go up for visits. There's also been a happy phenomena, I think, of increased attention to remote patient monitoring and acute care at home, which could have an enormous impact over time. Can you comment on that, Andrew? And then specifically, just to cap it, literally, does this, given your comments about moving to value-based care, will you be more and more open to global capitation contracts for primary care?
Yes. So first, we'll be offering those. I'm not that favor of the C word, but yes, we'll be offering those contracts beginning in January of 2021. We're already in discussions with primary care groups about those kind of arrangements. And to answer your first question, we are very enthusiastic about the opportunity, and another silver lining potentially in the epidemic is to move more care out of hospitals and outpatient settings and into the home. I'm surprised that Dr. Strongwater didn't mention it earlier because it's one of his passions, and we're working with the Atrius practice and an organization called Medically Home to see what kind of care can we move to home. That is more often where patients want to be treated if it can be done safely. And I know that the Mass General Brigham system is also doing some experimentation with hospital at home. So I'm very encouraged by that. We've had for a century a kind of a hospital-centric healthcare system because that's where the safest place to provide care always has been. And I think we need to move to a more patient-centered and home-centered healthcare system.
Well, that's great to hear. The second question, unrelated question, but back to the issues of equity and disparities. So it's really well known that so many adults, and I think more so in the minority community, either don't understand medical information or fail to act upon medical directions and prescriptions. So I was encouraged by your comments of about 37,000, I think, outreach efforts.
Yes.
Do you have any texture below that? I mean, what was the uptake on those 37,000? Did you have series of? Yeah, go ahead.
Yeah, we had a lot of uptake, and in some cases it was interesting. You call a member and it turns out there's another person in the household who is actually more at risk that we learn about. There was a lot of issues around medication adherence or compliance that I think you're suggesting that we're able to deal with. And so that kind of one-on-one case management can be very useful, guiding people to care. Gives us an opportunity to talk about vaccinations, both for flu and hopefully over time for COVID. We think all worried about the kind of vaccine hesitancy in our nation as a whole. And so there are lots of opportunities once you can get a person on the phone to identify where the risks are and then act on them. So we were encouraged by those, and we're going to continue to make these outbound calls and continue to use our kind of predictive analytics to reach out to members that we think are in need.
And do you have the capability to do a return on investment for those efforts? I mean, you've got a lot of cost on your side.
Yeah, we
to
do.
promote those.
I can't say that our actuarial team has done that analysis yet, but we're likely to do it. They tend to insist on it. And so that's something we'll take a look at and could get back to the commission on our results.
That'd be great.
Yeah.
Thank you.
Thank you.
Thank you. Are there additional questions?
I'll jump in with one more.
Please, David.
Dr. Nethersole, you mentioned some concerns around the indirect effects of COVID that you're observing with the children and patient populations that you serve. I was wondering if you could speak a little bit more about what are you worried about moving forward with some of those indirect effects? And Madeline, I would really appreciate your perspective on this as well. And not only the things you're worried about, but are there ideas or solutions that we should already be considering to be putting in place to address or mitigate those indirect effects on patients moving forward? Thinking about things like loneliness and trauma and anxiety, mental health and substance use disorder issues. So Dr. Nethersole, I'll start with you, but Madeline would love your perspective on this particularly.
Thanks, that's a great question. I think, in terms of some of the effects that others have talked about in terms of food security, I think others, there are community organizations that are addressing that. I think we have the capacity to be able to deal with those needs pretty well. I'm more concerned about some of the behavioral health effects. So and clinically, just what I'm seeing are kids who are coming in with issues around anxiety, isolation, depression, some eating disorders actually as well. So the combination of both observing what's going on around them in their home and in their communities, and the sort of trauma related to that, as well as the isolation from not being in school, not having the sort of social connections they have, along with the lack of physical activity that most people are having, which is not good for your mental health as well. I think that, as we get into the winter, which again, usually behavioral health, at least in children, does have a seasonal peak that goes up in the winter. I think I'm just very concerned that we're not going to have all the resources that we need to be able to address all the behavioral health and mental health needs that children and families have. And then developmental health is part of mental health. And so our kids who have developmental disabilities who are not receiving the services that they would traditionally receive are regressing. We've seen that in some of our kids. I'm glad that most of the schools have prioritized them for return to school first. But I see that as being another significant challenge.
I certainly have to echo what Dr. Nethersole just said. We've not only seen those things in kids, but also in parents and caretakers. So dealing with the tremendous stress, sometimes loss of financial stability, the anxiety associated with that, the fear, the fact that their normal changed so significantly, and things that they were able to do before are not able to do now, or they just have to do it differently. So it's been incredibly challenging. And for us, I cannot stress enough the need for resources for behavioral health providers. Yes, it was really good. And we are definitely grateful and thankful for the relief funds that we were able to receive, but those stopped. However, the needs are still the same, if not greater. We still have challenges in regards to infrastructure and equipment, and we are still challenged with what's going to happen and how we're going to continue to support our most vulnerable and our communities and the people that we serve, all of those individuals in recovery that have been greatly impacted by not only lack of access, but the fact that they're all of a sudden their support system disappeared. So that is something incredibly stressful for all of us. Not only being able to address the needs of our current communities and the individuals that we serve, but also making sure that our staffing levels are up to par, that we're also supporting the staff that are providing those services that have also been impacted in the same ways, if not more so, because they're essential employees, but at the same time, they're struggling in the exact same way our individuals are struggling, the individuals that we serve. So balancing those things, and then not knowing what else is coming our way, and not knowing what other levels of funding, if any, are going to come our way to support us, and what other resources we're going to be able to access. It's incredibly challenging. So focusing on those things, as I think, is very important.
Thank you. Are there any additional questions at this point?
One quick follow-up, Barbara.
Please, Don.
Yes, this may be too in the weeds clinically, and I'm not sure the panelists feel able to reply, but in addition to the follow-on mental health burdens, are any of you now tracking this emerging literature on post-acute COVID physical conditions? There seems to be a rather long list of perhaps chronic burdens beyond mental health that arise in COVID patients. If you don't feel qualified to comment, please don't, but I'd appreciate it if you do.
Don, we're not formally tracking it in the sense that I think you're referring to.
Thank you.
I think, however, that it's part of the unfinished business of this pandemic. We don't really have a good clue what the prolonged effects of this pandemic will be, either physically, emotionally, economically, psychically. We don't know. When this virus is done with us, it's not yet done with us. And I think that's part of the message going forward. So if there are no further questions, I want to extend our deepest appreciation to our panelists today for your thoughtful engagement and your willingness to participate with us. We are eternally grateful. We have hoped to learn from you, and I believe indeed we did. And so our appreciation to all of you. And with that, David, I think I turn it back to you.
Thank you. Thank you, Commissioner. Yeah. And thank you to really incredible panels. What a great conversation. Before we turn to a final board discussion that Chair Altman will moderate, we have one final really great video presentation. We had to move around a little bit in the agenda today to get to the panels, but I'm so pleased to be able to introduce our Attorney General, Maura Healey. The Attorney General, as the people's lawyer, works every day to fight for and protect patients and consumers in this Commonwealth. And that is a role that is just so incredibly essential during a pandemic. The Attorney General, as we know, also is such a powerful voice and advocate for so many of the issues that have been front and center of the conversation today. Issues around advancing health equity, issues around enhancing access to behavioral health care and substance use disorder care. We're proud to be able to work with the Attorney General's office on issues of social determinants of health and upstream investments. We're proud to work with them on monitoring changes in the healthcare marketplace. And we're really pleased to have Sandy Walensky from the Attorney General's office with us today, represented in this hearing. But I'm going to turn it now to a pre-recorded video from our Attorney General providing remarks to this hearing.
Thank you to Chairman Altman, the HPC Commissioners, Executive Director Seltz, and the HPC staff for inviting me to speak at today's hearing and for your ongoing commitment to improving access to health care in Massachusetts. Thank you to the health professionals, essential workers, and all others on the front lines of this crisis. You have helped us through a difficult first phase of this pandemic, shouldering extra burdens and risks, and we are grateful to you. Though the pandemic has affected all of us, the burden of COVID-19 we know is not falling evenly across Massachusetts communities. The data clearly show that Black, Hispanic, and Latinx residents are more likely to be infected by the coronavirus than white residents, and that communities of color continue to experience higher rates of COVID-19 deaths. Those hit hardest by the virus were disadvantaged, of course, before the pandemic even began. But COVID has amplified and exacerbated the social, economic, and environmental inequities that contribute to worse health outcomes in communities of color. For example, people of color are more likely to be essential workers, to rely on public transportation, and lack space to quarantine effectively at home, all of which put them at a higher risk of infection. In a recent report, my office found that long-term exposure to air pollution and other environmental harms make residents in low-income areas and communities of color more susceptible to the coronavirus. Air pollution disproportionately affects the health of Black, Latinx, and Hispanic communities in part because industrial facilities and highways are concentrated in low-income communities and communities of color. These social, economic, environmental inequities are not new. They are legacies of structural racism and racial discrimination that continue to harm the health and the well-being of marginalized communities, as they have for generations. In addition to bearing disproportionate adverse effects from social determinants of health, communities of color also suffer worse outcomes from our healthcare system itself. Though the Commonwealth is a national leader in health policy, the disparate effects of COVID-19 provide a somber reminder that our healthcare system still fails to equitably serve communities of color and low-income residents. In past cost trends reports, my office has shown that there's a mismatch between health need and healthcare resources. We spend most on healthcare in the highest income communities, even when we account for health need. We systemically underinvest in the health of vulnerable and marginalized patient populations. So where do we begin? To advance equity in healthcare, we need to take a hard look at how we deliver and pay for healthcare, and we must be willing to change long-standing systems that disadvantage marginalized communities. We must also recognize that the healthcare system alone cannot end health disparities, which are rooted in a broad range of deep-seated inequities. We need to expand our conception of what we mean when we talk about social determinants of health in our research and policy proposals. And at the same time, we need to focus on specific steps we can take now, in the next months, and in the next legislative session to address long-standing shortcomings in the opportunities and resources available to our marginalized populations. We need to think about educational opportunity and environmental justice, for example, as areas for action to address racial justice and equity, and also to address health equity. We can and must do this even while we sustain our focus on the healthcare system itself to continue to press forward on efficiency, access, and quality. My team's been focusing on these issues, and your participation in today's hearing suggests that collectively there is much we can do. Over the years, Massachusetts has taken bold action to address healthcare quality, cost, and access. I'm confident that we have the resources, talent, and vision to emerge from the COVID-19 crisis not only as a leader in healthcare, but also as a leader in health equity. COVID-19 has shown us that these actions cannot wait. With the support of policymakers, providers, payers, and other stakeholders, we can ensure that all Massachusetts residents, regardless of race or ethnicity, have access to affordable, safe, quality healthcare. Thank you for the good work you're doing and the work that we're going to do together.
Thank you, Attorney General. I think a very fitting message at the end of this hearing. Where do we go next? How do we make that vision a reality? And so with that, I will turn it over to Dr. Stuart Altman for a closing discussion among the board members.
First of all, David, even though we had planned to have the Attorney General speak early on, you couldn't have done a more magnificent job of rearranging it, because I think she laid out, as you pointed out, where the system needs to go into the future. And it really, she did in a more articulate way, raise the concerns that I raised in several of my questions. And that is, it's always easier from everyone's point of view, except the people that pay, to just add on. And in the short run, I agree with the comments that we do need to spend more. We can't change right away, but we do have to think about the future and whether there needs to be a restructuring both within the healthcare system, both in terms of where the money goes, maybe away from clinical care towards more money spent on the various social issues that have been raised today. I take really to heart the comments of the Attorney General, and now let me turn it over to a discussion among our commissioners to see any final thoughts on what was really a phenomenal, very well-packed, well thought out morning. So anybody want to jump in? Don't be shy.
I will,
Yes,
Stuart.
Barbara, please.
Thank you. I think part of the goal we established for this hearing was to become more aware of, and to borrow Thea's framework, more intentional about the issue of equity. I think she's given us a wonderful watchword: intentionality. And I hope we use it throughout the rest of our time, trying to bring the issue of equity with intention throughout the work that the commission does. I think I think we've had a very good platform for grounding us, if you will, in this work. And I think our panelists exceeded our expectations on this. So I'm feeling very positive about the work that's been done in this hearing. And I look forward to working with the staff to pull that together, to embed this work into the ongoing work of the commission in the coming years ahead. And it won't just be 1 year. This needs to be embedded. This needs to be foundational. And I think we're working very aggressively, and I hope very successfully in accomplishing that. So thank you.
Great statement. Anybody else want to give some final thoughts or ask some penetrating questions?
I'll just endorse what Barbara said. Stuart, this is a fantastic meeting, and I think David Williams kind of setting the stage was a great gift to us. The challenge for us is to think of actions. We see a lot of good stuff going on from the reports from the panelists, and I hope we can spend the time as a commission to dig into what else could be done in real terms, moving from understanding the problem to actually acting on the problem of inequity. Thank you for teeing this up, and David, the staff did a great job with this meeting. It's really a tremendously interesting and important set of materials you brought to us.
Thanks.
I'll jump in too. I mean, I just build off what Don and Barbara said, and I think the key word for me is action steps that we're going to be taking. And the presentation and the panelists was really impressive, particularly the presentation that we got, and just so much going through my head of where do you even start the work that we know lies ahead. And again, COVID laid bare the inequities of our system. And one of my fears is just thinking, and I think it goes to your question, David Seltz, that I also had just around the access to telehealth is one example of a lesson learned that we needed to expand telehealth. That needs to be applied going forward, but we know there's already an inequity of who's able to access telehealth in the ways that get the most benefit from it. So right here, we're with actions that we're learning and applying to the future, we're not addressing the equity issues there. So how are we dealing with some of the immediate lessons that we've learned and things that we know we need to apply? How do we start there with some of the thing, one of the ways to address some of the equity issues that is risen there? Just one small thing, I think it would have been really important to have a nursing home voice on some of the panels today if we're talking about assessing the impact of COVID. I think we all know the impact in our long-term care facilities was incredibly acute, with over 6,000 residents dying in the COVID crisis and pandemic. So I think it would have been good to have that perspective. I hope in the future there could be a discussion with the long-term care providers around some of the impacts, assessing that, and again, all the equity issues that arrive from that, because we do know that in most of the nursing homes, it's low-wage workers taking care of low-income residents. Talk about inequities in that system. And again, the one thing I'm just taking away from this whole thing is powerful presentations, a lot of work to do, and some immediate actions around applying the lessons to the future to ensure we're stopping the inequities of things we know needs to happen. One thing that popped in my head when we heard around the hospitals at home, who's that going to have access to those hospital home model? Blue Cross members, that's great. Partners hospitals, that's great. But how are we expanding that to the populations that were impacted the most by COVID and have been impacted the most by healthcare inequities? Those are just some of the things that popped in my head, and just to apply those lessons now to the future responses to this pandemic and other healthcare issues that come forward. But a really good hearing, and thanks again for David and the other commissioners and the staff for putting together a great discussion, and a lot more that needs to come out of it and be intentional in our work going forward.
That's great. Thanks. Any other final? Ron, you want to jump in? Yep.
Thank you. When looking at, first of all, I found today to be very educational personally. And I'm thinking about this whole inequity thing. And we're living in a world where we're basically joined either one side or the other. And in listening to the presentations, I was thinking about how can you bring people together? And I thought the slides that David Williams presented on the impact to the economy if we do have equity in our society, I think that's something that people, regardless of on what side of the political spectrum you may be on, may be a real awakening for people to really look at the benefit of providing equality across the board, because it does benefit all of us.
Great comment, Ron. All right, we're just at the bewitching hour, but I want to make sure we get it. Barbara, would you like to say something more? You have your hand. Okay.
Stuart, if you can indulge me for just one more moment. I don't want to leave here without taking a moment to reflect on what's about to happen to our clinical staff in every environment. Where all indications are indicating that we are going to get slammed over the next 12 weeks or so, that this winter is going to be extraordinarily difficult, and it will fall heavily across the board. But I think especially of our clinicians and our folks working in hospitals and in care facilities at whatever level, and the care that they offer and the demand that it takes of them to do it. And I just want us to take a moment to acknowledge them before we're done, because they're gonna carry a huge brunt and a huge burden, and we need to acknowledge that, and we need to remember to be grateful for it. So thank you for indulging that.
Well said. Well said. Let me now turn it back to David.
Commissioner Cohen, did you want to add a few words?
Yeah, I just sort of echoing what Barbara added. I think we also have we currently have a behavioral health crisis, stress, anxiety, depression, drug and alcohol use, suicidal ideation that is only going to get worse in the next several weeks and beyond. And I think it's something we need to pay attention to. And while I appreciate what Blue Cross Blue Shield has done regarding the permanency of telehealth visits, that's not the case across the board. And that's going to be very important if we need access to both mental health and substance use care. So I'll just leave it at that.
Okay, David.
Well, thank you, commissioners, for a really excellent hearing. We pulled it off. This was really an incredible morning. I couldn't be more proud of the conversations, the discussion, and I do too feel educated and inspired to continue this work, to continue the actions and the attention and the challenge that you've laid out for us to work together. I also really want to thank again our speakers, our video presenters, our panelists, who all took time out of their days to pre-record videos or to be here today in the Zoom session. Just such heartfelt appreciation. And especially again, for those that participated in that compilation video that we showed at the beginning of the hearing. Again, thank you so much for all of the time that went into that and those voices that were a part of that. And I just want to let the public know that that separate video of compilation of voices from the Commonwealth is going to be posted separately, and really would encourage you to share that with your networks. But Stuart, commissioners, thank you. And Stuart, I will give you the last word on today's hearing.
I'm sort of humbled by what happened, what we did today. It was great. And I really want to thank our commissioners for their insightful comments. And you, as you pointed out, our panelists were great. We heard from a number of people we hadn't heard from before, and I give credit to our staff for anticipating that. So unless there's anyone that really wants to say something, I would welcome a motion to adjourn. No, and hearing nothing,